Scarcity of audience at the moment, but surely with so many good speakers, we will soon have a wonderful session here. Without much ado, since Rajiv Brahman is not here today, may I request Dr. Arvind Gupta to take the first talk of today, PCL aversion fixation by arthroscopic technique. Dr. Arvind, please. राजीव रामन चला गया
किससे बोले दीजिएगा
So, good morning all. So, this was the topic assigned to Dr. Rajiv Brahman, but he is not here. So, I will be covering this PCL tibial spine avulsion fixation by arthroscopic knee. So, we all know the anatomy of the PCL. Over the posterior aspect, it attaches to the posterior part of the tibia almost a centimeter to 14 millimeter below the articular surface. And most of the time mechanism of injury is the direct blow over the knee when patient is in almost knee is in 90 degree of the flexor. And there is classification given for it. So type 1 is almost undisplaced fracture, type 2 is minimally displaced, and type 3 is complete displacement. And literature recently in 2022 says if displacement is less than 5 millimeter, this fracture can be managed conservatively. So about the surgical treatment, when type 3 displacement is there, and it should be confirmed clinically also. You can see the translation is almost more than a centimeter. It means the displacement is quite high, and such type of fracture should be treated surgically. This can be done by open method also. That was first quite long time ago described by the Bach and the Sappers, and recently modified by the Lovenhofer method. So this is the open method treatment, and this was the case presented to me. You can see the displacement of the tibial spine, that is almost more than a centimeter, and the clinical test was positive. Almost a centimeter displacement was there. And this was the arthroscopic picture. So go in between first, in between the ACL and the PCL, the transeptal, dissect all the fat pad. Be careful about the damage of the PCL and the ACL, that should not be there while making this portal in between ACL and PCL. And after doing all the debridement of the soft tissue, then you should go to the posteromedial corner in between the PCL and the medial femoral condyle. Then make a portal from there, that is posteromedial portal. Here you can make a single portal also, that is the working portal, or you can make the two portal, that is one is high anteromedial portal, another is low anteromedial portal, so that you can see from there, and at the same time you can work from there. So here you do the dissection in between the PCL and the capsule, remove all the soft fat. So this is how, this is the complete removal of the fat pad and the tissue with the PCL and the capsule, and identify the fracture fragment there. Then you pass a tape from the septum in between the ACL and PCL, and then make a roll against the PCL and take it through the posterior medial portal. And after that, this is against the PCL, and then pass a jig that should be almost 10 to 14 millimeter below the articular surface over the crater area from where it is avulged, and you can see it from the anterolateral portal also with the help of 70-degree scope. So you can see almost down. This is the 70-degree scope I am seeing from the anterolateral portal only, not from the posterior medial portal. So here you can see the jig is there, and after making the drill, you pass the SS wire or bead pin with the fiber wire from there, and then take this SS wire in the anteromedial portal, and then you railroad the fiber wire from there. I don't put any knot around the PCL at the junction of tendon and the bone. Just it's the circle of this fiber tape. Usually I use either two fiber wire or one wire or one tape. Then you railroad this fiber wire and tape entirely. You can see, and this is the floppy ACL side. Once this pulled entirely, you can see this floppy ACL side will be lost. Just see this. Once you you can see the floppy ACL side was lost. So this is how this get fixed at the 90 degree of the knee flexor with complete translation of the tibia anteriorly. And this was another case having ACL and the PCL spine avulsion both. Nowadays, because of motor vehicle accidents, is the common injury, and that both ACL spine avulsion fixation and the PCL spine avulsion fixation was done at the same time. Another case with big bony fragment of the PCL spine, at the same time ACL spine avulsion was also there. So fixation of ACL spine and the PCL spine was done, and this was the healing of this ACL spine. ACL spine was fixed a little bit anteriorly, and the PCL was quite normal. This was the clinical picture of this patient with ACL and the PCL spine. Post-op, always posteriorly there should be any bump, or it may be the modular brace comes that keeps the tibia anteriorly, so that your ligament is in maximum tension, this won't get contracted with the time. Usually till 6 weeks it should be the partial weight bearing, and then range of motion can be started early also. Thank you.
Shall we take the questions at the end? Yeah, can I ask the next speaker to come? Dr. Uday Kumar. He's going to talk about post-ACLR infection, point to ponder.
Respected Chairperson, good morning everybody. My topic of presentation is post-ACL reconstruction infection. What are the points to ponder? So the post-operative post-ACL reconstruction infection is deemed to be one of the most dreadful complications we have incurred in our practice, although it is very rare and uncommon. If it occurs, that leads to the chondrolysis, graft failure, and arthroplasty of the knee joint. Its incidence varies from 0.14% to 1.8%. There is debate regarding the management of the post-operative ACL infection, whether it should be debrided by arthroscopic or open method, retention of the graft versus secretion of the graft, retention of the implant versus removal of the implants, and how long the antibiotic we have to continue in the intravenous or the oral method. So don't take the arthroscopy procedure lightly, although it is a keyhole surgery. The prevention is better than the treatment. We all of us know about it. So the pre-operative preparation, just clipping the hair, don't shave the hair. Check the sterility of the instrument before going for the procedure. Intraoperative care of the graft. Keep it minimum contact with the skin and soakage of the graft with the vancomycin or gentamicin. And post-op measure at least 2 doses of post-operative antibiotic mandatory. So the diagnosis is classified into 3 phases: acute, subacute, and chronic. Acute when the patient presents within 2 weeks, subacute between 2 weeks to 2 months, and chronic after the 2 months. Most of the patient presents in the phase of acute and the subacute phase. Started from 7 days to 62 days. The fever is high grade fever is there, and there is excruciating pain. Any patient who have arthroscopic ACL reconstruction, initially 1 or 2 days there is pain, but once the pain is increasing in nature after 2 days, that it should be keep in mind there is something wrong. Knee fusion and local rise of the temperature. Painful joint range of motion, joint diffusion, and high grade fever strongly favor the possibility of intra-articular infection. The serum analysis, there is increased WBC count. The joint spirit is the gold standard diagnostic test for the infection. The positive synovial fluid, there is gram staining, and the culture we have some organism came. In the negative synovial fluid analysis, when there is the WBC count is more than 1 lakh, then it is the signal for the infection. In case of aspirate is negative, then C-reactive protein and the ECR helpful for the diagnosis. See, this is the post-operative case of ACL patient. There is effusion, pain, redness, and never ignore these signs. This is the redness around the knee, and there is some swelling around the tibial side. That is not the normal. So once the suspected, don't wait in this patient. Just aspirate the joint, send for culture and sensitivity gram staining. Any suspected knee joint infection is an emergency situation. Serial arthroscopic lavage and IV antibiotic with graft retention remains the most efficient treatment protocol in most of the patients. So the knee lavage is with the 10 to 50 liter of the normal saline with added vancomycin or gentamicin. So the arthroscopic debridement and lavage is the key for the success of this post-operative ACL reconstruction surgery. We started the debridement from the suprapatellar pouch, medial joint line space, intercondylar mass, lateral joint line, and don't forget to debride the posteromedial and posterolateral compartment of the knee. Do the extensive removal of all the necrotic tissue, near total synovectomy, and debridement of the fibrinous exudate of the graft surface, and lysis of the fibrous adhesion during the lavage. Sometimes there is second arthroscopy needed in this patient when there is persistent sign of active infection, that is, a persistent fever unresolved inflammatory marker, that is the ESR and the CRP, did not come down more than 50% of the initial value. Persistent wound drain and warm and erythematous knee. And this second arthroscopy we do on the third day of the first lavage. The second arthroscopy recommends the additional surgical debridement. It lowers the infection burden, chronic infection, synovitis, progressive condyle deterioration, and post-operative stiffness of the patient. So there is debate whether we should continue with the graft or just sacrifice that graft. So the graft removal is indicated when there is significant intrasubstance degeneration, gross evidence of infection comprising the graft viability, and there is MRSA organism identified in the culture and stain, and there is non-functional graft, lax graft, or leach unstable. In that situation, we have to sacrifice the graft. So the antibiotic duration, the IV antibiotic duration is for 7 to 10 days, followed by 6 weeks of oral antibiotic according to the culture and sensitivity report. The post-op care, closed suction drainage system and continued irrigation system for 2 days. Immobilize the patient in the long knee brace with gentle range of motion. These patients are very prone to fixed flexor deformity, so we have to keep watch on that. So the take-home message: once the infection is suspected, try to attack early. Don't waste your time. Don't suppress infection with the antibiotic. Joint lavage and debridement is the keystone of the success of this post-operative ACL reconstruction infected patient. So this is the recommendation in all the India, the prominent arthroscopic surgeon, and these are their view to prevent the surgical infection. You don't go for the shaving, just clip the hair with a clipper, and preoperative antibiotic prophylaxis with the ciprofloxacin, then antibiotic soakage with the graft with vancomycin or gentamicin. The vancomycin is preferred at least for 15 minutes, and at least 2 doses of post-operative antibiotic after the surgical procedure. Thank you.
Thank you, Dr. Guru, for such an important topic. We have covered it in such small span. So, as decided, we'll go ahead with our next talk. The next talk would be by Dr. Manish sir. He'll be speaking on anatomical variants of intra-articular position of long head of biceps and its clinical significance.
It's very not widely covered. So we have taken this topic as a study in our institute, and few of my PG students are working on it. So they are basically the anatomical variations of the intra-articular portion of the long head of biceps and whether it has got clinical significance or not. So as such, to begin with, the biceps breaker has got 2 origins, the long head and the short head. The long head of biceps has got origin either in superior tubercle or glenoid tubercle with the incidence of 50% for each. So variants have been seen regarding the origin of long head of biceps in 1.9 to 7.4% of cases. And long head of bicep tendon has always been a subject of study not only because of its variations in the type of pathology it has, but also because of its variation on the attachment of the glenoid. Typically, the tendon has got a free intra-articular course, an extra synovial one, and it is encircled by the synovial lining of the articular capsule. And that lining extends up to the inferior-most aspect of the vertical groove. So embryologically, what has been seen is that the long head of biceps transmigrates from outside the joint into the joint. And during this process of transmigration, because of incomplete separation from the synovium or the mesothelium, variants are created. So with the advances of arthroscopy, the recognition of these variants has increased. Derricks had identified almost 57 cases of variants in his 1976 arthroscopy which he performed. And he broadly divided them into 4 types: the meso, adherent, split, and the absent type. A study by German and others, they found a variance of around 6.5%, which was similar to the previous studies. But in his study, he could not identify the split and the absent type. He found only the mesotype and the adherent type. So the possible reason in his findings could have been the race here, because most of his participants were Korean. Some of the studies, they have shown that the variants can happen in both the shoulders. But in his study of Jung, when he performed this study, 2 cases were operated on both the shoulders, but he found variant in only one. The other study was undertaken by Grigg and others. He performed study on the cadavers, and 130 cadavers were studied, and in that, about 28 cadavers had some variants regarding the origin of the long head of biceps. In his study, he found that bilateral variants were seen in 5 cases, symmetrical variants were seen in 3 cases, origin from the joint capsule that was seen in 3 cases, and his study supported that the bilateral variants are rare. So what was the aim of our study, or what is the aim of our study? Basically, the relationship between the variants and the shoulder disease is controversial. So anatomic variants are encountered in our daily practice, but we do not identify them, and we don't know whether it has got significance or not. So a better understanding of these variants can prevent the misinterpretation for them to be a pathological entity. So the study was aimed to detect the frequency of the variants during shoulderscopy, classify them based on the Dedek's classification system, and to analyze the frequency, demography, and the relationship to the shoulder disease for each type of variants. The matrix method, after getting ethical creation from an institute, the patient between the age group of 18 to 65 years would be enrolled for the study. The patient coming with OPD or the emergency, the IGRMs. The inclusion criteria would include the non-referred shoulder pain, the symptoms of instability, pain during the throwing movement, or the painful arc with the features of rotator cuff lesions and stage 1 of periarthritis. And the exclusion criteria mentioned below. In the matrix method, the patient would be placed in lateral decubitus position for the scopy. Posterior portal would be used as the viewing portal, and either 1 or 2 anterior portals would be the working portal. Variants would be classified according to Dedek's classification system, and the frequency of each type, at age, at the time of the surgery, the gender of the patient, that everything will be noted down. And we will see the correlation of the variants with the different diseases is unclear yet. And it is also said that traditionally that the variants as such do not cause the disease. So this is the position of the patient for the scopy. And according to Dedek's system, there were 12 types of variants, which was broadly classified into 4 types, as the mesotenor, adherent, split, and the absent. This is one example of the meso-PU type. It has got a pulley sort of, you can see the pulley sort of structure there. This meso complete type of meso is adherent PM. That means it is attached on the posteromedial aspect, partially adherent on the medial side. This adherent type, it is a complete adherence, but it is not attached to the supraspinatus, it is attached to the labrum. Another type of variant, adherent, complete type of variant. So as the study has not started yet, but what we are planning is, as per the Jane study, the long head of biceps morbidity was divided into 3 types. That is the dislocation, subluxation, and the partial tear. The subluxation is placed where the tendon is positioned more medially within the biceps groove, whereas dislocation is positioned superior to the medial border. So what the studies, they have shown that in the variant group, the percentage of variations, that is the dislocation and subluxation, that is seen in 7%, whereas the partial tears are seen in almost 20.9%. Whereas in normal group, the dislocation and subluxation incidence was 7.5%, whereas the partial tear incidence was around 33%. Frequency of long head of lesions, it is low in case of variant group. So that was in the previous studies. So in the variant group, some of the common diseases which can be encountered, they are the rotator cuff tears, the slap lesions, adhesive capsulitis, and instability, with the percentages I have shown you. So finally, the mesotype, what has been studied till now, the mesotype are showing a lower frequency of rotator cuff lesions. And there is increased incidence of shoulder instability in the mesotype, whereas the adherent type, they have got a similar distribution of disease as was observed in normal group. So what can be the limitation of my study? Because this study is conducted on patients with some shoulder pathology, the frequency of variants would not be able to determine in the normal population, because the normal population is not taken into consideration. And the second, the exclusion criteria was the patient with previous stenotomy, tenodesis, and complete self-rupture. They are also excluded from the study. So if these factors are also present and they have got certain variations, that can also be not determined in my study. So it is necessary to carry out further study on a larger number of subjects, and in whom we will include both the normal as well as the symptomatic patients to come to a proper conclusion. So the take-home message can be, the take-home message is, anatomical variants are present but it is overlooked. What your mind doesn't know, your eyes can never see. And one should try to correlate the variants with the pathology if present. Thank you.
Thank you, Manish. Excellent presentation. Certain anatomical variation which we need to think about. Going ahead, may I request Dr. Arvind Gupta for his next talk, Common Causes of Shoulder Dysfunction.
This was very big topic assigned to me by Dr. Ramesh India. So let's see how much I can cover. So shoulder joint pain is still a very complicated thing to diagnose from where this pain is coming. So this shoulder problem can be categorized into 4 types. Started from the stability to problem with the strength in form of maybe rotator cuff tear or impingement. There may be problem of smoothness, that is arthritis, or finally the most common diagnosed problem is the frozen shoulder or adhesive capsulitis. So I'll start with the unstable shoulder. Shoulder gets stabilized by static and dynamic stabilizer. In static, the bony component and the labrum. Labrum almost increases the surface area by 4 times, and the capsule and the ligaments. In the capsule and ligaments, the IGHL is most important one because it's come entirely in position when the shoulder gets dislocated. When 90 degree of abduction and external rotation, this IGHL make a fine separate structure, and this prevent the dislocation of shoulder joint entirely. About the dynamic stabilizer, it is the rotator cuff at the same time a scapulothoracic muscle that is all around the shoulder joint. For making the diagnosis about the unstable shoulder, it may be subluxating or may be dislocating. So it started from the timing, first, last, how many, does your shoulder hurts also, and what was the mechanism. At the same time, there is some red flag signs. Like patient if say, I don't remember when shoulder get dislocated. There is constant pain even after reduction of the shoulder joint. It gets dislocated in each position, even in 30 degree or 40 degree of abduction and external rotation. Patient always keep a sling around the shoulder. And be careful when there is dislocation in the elderly population more than 60 years, because the chances of cuff tear at the same time is very high. And the patient knows highly history of the season. And some are voluntary dislocated. Like this patient who is voluntarily dislocated, he thinks he is Superman. He can do anything around the shoulder joint. So treating such type of patient or treating the cause of pain in such type of patient is very difficult. Next is the clinical examination that starts with the provocative test in form of apprehension test and the 90 degree of abduction and the external rotation. Just check for whether patient is having apprehension of the shoulder dislocation or not. You can see the patient is not aligned the same. Next is the mid-range instability. This shoulder getting dislocated even at the angle of 45 degree of abduction and the external rotation. It means there is big bony lesion or palmar lesion is there. The patient is having apprehension at this much of angle. Next is the jaw relocation test, the load and shift test, and the circus test. All these tests help in making diagnosis of anterior shoulder instability. And there is instability severity index score, and the higher the score, the chances of recurrent dislocation or subluxation is very high. At the same time, the glenoid bone defect measurement is also very important in such type of cases. The landmark is 20 to 25% of the bone loss from the glenoid lesion. The MR help in making the lesion, identifying the lesion in the soft tissue, that is the labral, capsular. At the same time, the quality of tissue can also be identified. The posterior instability, 99% of the cases present with the pain around the shoulder. Like this female lady saying there was a pain all the time when she walks. But if you ask the patient to do this test, she will subluxate voluntarily posteriorly the shoulder joint. But she don't complain about any history of the subluxation or dislocation. Only she will complain about the pain around the shoulder joint. So for the decision making, combine all these things, history, examination, imaging, at the same time the instability severity index also. Like this case presented to me recently with a history of shoulder dislocation almost 1.5 months back. He worked at Bangalore only. The right side shoulder was operated by me almost 8 years back. You can see the metallic suture anchor in the right shoulder, and the left shoulder recently he dislocated, and the shoulder immobilizer was removed after 2 weeks. But even after removal of the shoulder immobilizer, after this reduction of the shoulders, he has pain around the shoulder by doing any movement. So a doctor advised there for surgery. He came back to Patna. If anything has to be done by primary surgeon. So he came me, and this was the MRI of this picture. On the left side, he has only one time shoulder dislocation, and you can see the anterior and the posterior labrum was completely lost. So even with the first time dislocation, you can have picture of something like this. That is the palmar tear. You can see the anterior labrum is completely torn. The inferior labrum is completely torn. The posterior labrum is also completely torn, and it's coming till the superior labral region. So it was a complete pan-labral lesion only with the history of first time dislocation. So here the symptom was the constant pain around the shoulder joint with any movement. So all the time labrum was getting pushed with any type of movement because of the pan-labral tear. And this was how this patient was treated with complete repair of all 7 ankle was used by complete repair. In the posterior part, this knotless ankle was used. In the anterior part, knotted ankle was used. So the slab part was also treated here. This was the knotless ankle. Push lock was used here, push lock, here push lock. And in the anterior side, this was the knotted ankle. Next pathology in the instability is the slab lesion, that is superior labrum. That is attached with the long head of the biceps, torn anterior and posterior. And symptom is patient having problem with the overhead activity. He cannot put a slab on the cheek of another person. That diagnosis is slab lesion. And the test is the O-gland test, the slab, that bicep load test, and again should be treated with the 2 ankle fixation in the superior labral area. The next problem of the weakness, that is the cuff tear. Just listen the history of this patient. So he was saying that he cannot lift the shoulder, and once it is get lifted by another hand, his shoulder get dropped. So this was very common history. Pain along with the weakness. Patient cannot keep the shoulder in 90 degree of abduction. At the same time, the external rotation was also lost. You can see the clinical test here. The drop arm test the patient cannot hold his arm in abducted position. You can see this is getting down. On the left side he can hold. The external rotation lag test. On the left side he can exert the force, but not on the left side. Then the first subscap, the Bailey press test. And the Bayer hack test. This was good force here, so subscap was okay, but external rotation and this jaw test was it was the problem with the supraspinatus and the infraspinatus. So this was this is the tear which classifying maybe mild, moderate and severe grade. If it is coming to the level of the glenoid, that is the massive cuff tear. So this was in this case, it was retracted till the layer of the glenoid. Here you can see, and there was tear of the supra and the infraspinatus, subscap was intact. This was repaired with double row, knotless anchor. The medial row is there, lateral row is there. And this is after the 4 months of this surgery. He is a farmer working at involving in all this farming activity. So he can do now all the activity. So he can lift his bundle also. Another case, you can see there was hardly any movement around the shoulder actively. Passively, she can doing all the activity. So, Dr. Neha, what is your diagnosis in this case? Actively, there was hardly any movement around the shoulder, but passively, it can be all the movement was intact in this case. So, supraspinatus tear was definitely there, but because hardly any movement, even initial 15-20 degree he cannot lift. So, this was the case of pseudo-paralysis. In pseudo-paralysis, hardly there is any active movement is around. Your supra, infra, all the muscle is taut, and the patient completely lost of the movement. So, if you see the MRI picture of this case, the humeral head is completely translated. There was hardly any cuff in this case. And in the axial section, you can see there was complete atrophy of the supraspinatus and the infraspinatus. Yes. Just give me a little bit time because next speaker is not here, so I take the opportunity of that.
I'll take the opportunity.
So this was a case of pseudo-paralysis.
Intentionally.
So this was treated with the reverse shoulder orthoplasty in this case because the cuff was almost irreparable and there was lot of fatty infiltration in this case. And this was after the 2 months of the surgery. And this is the clinical picture of this patient. Patient can now lift. Now he can do most of his routine activity. So next is the problem of the smoothness, that is the arthritis. So lot of these arthritis patients diagnosed as adhesive capsulitis or frozen shoulder, particularly in early stage of arthritis. Though this was a very young patient, hardly 28-year male case of ankylosing spondylitis. All the time there was no X-ray with this patient, but patient was treated for last 2 years as adhesive capsulitis, even with intra-articular injection also. But this was the patient of arthritis only, so this was treated with the primary shoulder replacement in this case. Next is the main most common problem, that is the adhesive capsulitis. There is lot of problem associated with this, and we all know with normal X-ray, the first thing that should be there for diagnosing adhesive capsulitis is the loss of external rotation. If external rotation is normal and other movement is lost, then it is not a case of adhesive capsulitis. And we all know the most common ligament involved in this case is the corophumeral ligament. Because of this, the external rotation gets lost in first, then other movement get lost. So absence of external rotation should be there. With all these, I'll inviting you all at 6 Bihar knee orthoscopy and osteotomy course with 5 or 6 live surgery with hands-on workshop on the HTO high table osteotomy at 1st and 2nd April. Venue is same, Roria Hotel Bali, that also hall is there. Thank you.
Thank you very much, Dr. Arvind. I would now request Dr. Ravi Kumar to talk on revision ACL reconstruction, one stage or two stage.
Good morning, everyone. I shall be speaking about revision ACL surgery, one stage or two stage surgeries. So I'll just go through the introduction and then why are the ACLs failing, when planning a revision ACL reconstruction, the graft choice, whether to go for one stage or a two stage surgery, and a couple of literature reviews. So arthroscopic ACLs is one of the most commonly performed knee surgeries with an average success rate of 90%. With increasing number of primary ACLs being performed, the incidence of revisions for the failure of the ACL primary surgery is also increasing. So first of all, what is a failed ACL surgery? There has never been a consensus about this. Previously, it was all about grade 3 pivot shift positive or more than 6 mm of anterior-posterior laxity on arthrometer. But of late, Johnson and Fuelfu, they just broadened the criteria. They chose to include presence of instability and or pain and or stiffness. So patient can have one or more than one of these three to be labeled as a failed ACL. So ACL revision rate for adults is reported at 4.1% in Danish registry. Well, if you look at the American and the Norwegian registries, it's just 0.9 to 1.5%. And the failure rate again varies as per the graft used. The failure rate for the autograft ACL was found to be around 2.8%, and the failure of the allograft is very high, as close as 13%. So why are the ACLs failing? So there was an audit of the tunnel position after ACL reconstruction, and they found that close to 65% of the femoral tunnels and 59% of tibial tunnels were in bad position in the sagittal plane. So if you look at the ecological factors responsible for the ACL failure, it can be broadly put into three subheadings: surgeon related, patient related, and the biology related. Amongst all the factors, the most common factor are the technical errors, which are well within the hands of the surgeon. After the technical errors is the recurrent injury. Coming to the technical errors, non-anatomical femoral tunnel are the most common, followed by the non-anatomical tibial tunnels. So what happens whenever there is a malpositioning of the tunnel, femoral or tibial tunnel, it can either it leads to failure by two reasons. Firstly, because of the inadequate restoration of the rotational stability, that leads to mechanical failure in the long term. Secondly, it can lead to graft impingement. The impingement can happen to the PCL, to the lateral femoral condyle, or to the internal condyle notch. So whenever there is an impingement, it causes graft failure by gradual overstretching and thus leads to mechanical failure. And secondly, it also hampers the biological healing of the graft. So again, it causes the ACL failure. So planning a revision ACL reconstruction. A failed ACL reconstruction does not always mandate a revision surgery. A patient with a either tricompartment osteoarthritis, those without recurrent instability, those having sedentary lifestyle or unwilling to participate in rehabilitation are not the ideal for the revision ACLs. For them, all required is a physiotherapy and activity modification. Coming to evaluation of patient for a revision ACL, we need to have the primary surgery details, like what was the graft used, the graft dimensions, the tunnel dimensions, what was the drilling technique used, especially for the femoral tunnels. Was that transported technique used, was through the transtibial or through the outsiding technique? Then what was the fixation methods used, like fracture fixation or suspensory fixation? And what were the intra findings, like was there any associated meniscal lesion, especially meniscal root and body tear lesions? Then was there any associated cruciate ligament injury, PCL or collateral injuries, or caudal lesions? Coming to examination, gait is very important. We have to watch out for antalgic gait. We have to watch out where the patient is having varus thrust gait. On inspection, just look for the apparent muscle wastage, status of the skin, scar marks present around the knee joint. Look for the joint line tenderness, that would suggest if the patient is having a meniscal injury or not. Look for the knee effusion. Coming to movement, the complete range of movement has to be quantified. That is very crucial in planning a revision ACLs. Then a special test for the collaterals, both collaterals, cruciate ligaments, and lastly, but very important, is examination of the contralateral knee. Coming to imaging, these are the routine imaging. We need to have a weight bearing, AP and lateral views, Rosenberg views, Skyline views. The objective is to rule out osteoarthritic changes in the knee joint and to watch out for the tunnel position. Then comes radiographs to rule out coronal and the sagittal plane deformities. We need to have a true lateral view of the knee with a full length tibia to rule out, to evaluate the posterior tibial slope. Next is, if on clinical examination we are expecting a patient to have a collateral ligament injury, then a stress view in 20 degree of flexion is very helpful. Opening more than 4 mm is suggestive of a collateral ligament injury on a varus or valgus stress test. Last but not the least, and it's very important, to have an anterior posterior standing full length scanogram. Watch out for the mechanical axis, whether it passes medially or it's normal. This corrective osteotomy, if required, always takes precedence over the revision ACLs. First, you have to correct the deformity and then go for the revision ACLs. CT scans are the CT scan is the investigation of choice to evaluate the femoral and tibial tunnel positions. The measurements are made, basically we quantify the tunnel dimensions. Measurements are made perpendicular to the axial plane of the tunnel at the widest portion. This is the widest portion and you can see it's around 14.3 mm. Next comes the MR scans to identify soft tissue lesions, graft ruptures, synovitis, impingement, muscle infection screen, very important. Needs to be ruled out prior to planning any revision ACL surgeries. So this is a small, this is a flow chart. Depending upon the history, clinical evaluation, lab investigations, scanogram, MR or CT scans, patients can be divided into infective and non-infective groups. If the patient falls under an infective group, then correct the infection first and then go for a corrective osteotomy or a 1-stage or 2-stage revision. If there are no signs of infection, we can directly go to a 1-stage or 2-stage revision. This is the last observation. So graft choice in revision ACL, autografts are always preferred. No doubt about that. In autograft, the risk of revision is least in bone product and bone graft, then comes a hamstring graft. Allografts are better avoided because they have higher repair rates and the inferior patient-reported outcomes. So majority of the revision ACLs can be performed as a 1-stage. The ideal indication is a completely non-anatomical tunnels. Dilatation. All required is to make a new tunnel. The less than ideal indication is anatomical tunnels with no or minimal dilation. Then tunnel dilation up to 14 mm can be done in a single-stage revision surgeries. Coming 2-stage revision, in certain situations, it may be prudent to perform the revision ACL in 2 stages to avoid suboptimal graft choice tunnel position. 2-stage procedure is performed in just less than 10% of the revision ACLs. So how do we proceed in 2-stage surgeries? The first stage includes removal of the hardware, granulation tissue, walls are freshened up. Then we do the bone grafting. Bone graft incorporation is best assessed by CT scan at 3 to 5 months. And the second stage is planned at 4 to 6 months. So this is an indication for aseptic one. So one stage aseptic, one stage of two-stage revisions. So I'll just go through the literature review. So this is a meta-analysis which was published, and they found that two-stage revision demonstrated comparable clinical outcomes. So to take home message. It is vital to identify the cause of failure of the previous surgery and rectify them while avoiding the same errors again.
Excellent questions, Ravi. Now all the people were very interesting, and I hope questions from the audience would be very much expected, happy. So we will limit it to four questions. Yes, sir, please.
Last speaker for the ACL revision surgeries. When we talk about the slope of the tibia as such, it is not a varus deformity which is a cause of rupture of ACL, it is a posterior slope. So I think it becomes a priority if you are going to go for revision. If you want to correct the posterior slope also. Only the varus deformity correction.
So of course, we need to watch out for both the coronal and cerebral plane deformities. If the coronal plane deformities is more than 2, it requires corrective osteotomy. And even
slow increase is associated with rupture of
slope more than 12 degrees requires deflection osteotomy.
Okay, thank you, sir. Thank you.
Any question?
Sir, I have a question with Arvind sir. Sir, you spoke about the anterior and posterior lateral tear. So what is, yes, a paralateral tear. So what is the order of fixation? Like you have to fix the anterior labrum first or the posterior labrum first?
So it's depend upon where you want to fix, there is no problem. You see from the anterolateral portal. So you can work in the posterior part also and the anterior part also. In this case, first I took the inferior labrum first because that was the most unstable labrum. That was very subluxating almost. So first I fixed the inferior labrum at the 5 o'clock and 7 o'clock. Then I fixed with the knotless anchor on the posterior labrum. Then the anterior labrum, then followed by the slap lesion. Two labrum.
Sir, if we are visualizing from the posterior portal, then should we go for the anterior labrum first and then come to the subject?
Anyway, if you want to treat the posterior labrum, then you have to come on the anterior side. Your viewing portal should be anterior side. Then only you can fix the posterior labrum. So if you want to fix anterior side, there is no problem. You fix the anterior part, come to the anterolateral side and do the posterior labral part. No problem.
Okay, thank you, sir.
I have a question. In post-septic ACL failures, so what is your treatment algorithm?
Yes, post-septic knee, suppose the patient there are two types of infection. One is the intra-articular and another is the extra-articular. Extra-articular infection, no need to go for the joint debridement and arthroscopy, lavage, no. Just open the wound over the tibial site, do the debridement and remove the icky bond and whatever is there, just clean the dressing. That much is sufficient. Once there is intra-articular infection, then definitely it's a concern. In the first step, we have to go for the aspiration of the knee, same for the culture sensitivity gram studying like that. Then do the thorough lavage, all the knee compartment, posterior, medial, lateral. Remove that almost total sanopectomy of the knee. Then check the status of the patient after the primary debridement. It should be the ESR and CRP, it should be below the 50% of the initial value, and there is no pain, fever subsided and the swelling subsided. If all these parameters did not subside and the ESR and CRP not reduced, then we have to look for another debridement after the 3 days of the first debridement. And in that situation, again we do the thorough lavage, and both the time we add the vancomycin or the gentamicin in the saline, and it should be at least 10 to 50 liters of the saline for the lavage. Regarding the graft retention and removal, If the knee is stable, the graft is okay, then we retain the graft. If it is MRSA infection, it's lax, not stable, degenerated, in that situation we have to remove the graft and go for the another.
Dr. Gurudev, do you think any discharge in post-ACL condition in the anterior part of the tibia is not having any concern with the intra-articular thing? It's always associated with the intra-articular pathology only. Any discharge at the tibial tunnel in case of ACL reconstruction, almost 99% of the cases it is because of the intra-articular pathology.
It is associated with intra-articular pathology, but most of the time patient did not have such amount of pain and swelling like that. In that situation, you just do the extra-articular debridement and dressing, it will resolve. But once there is excruciating pain and pain did not subside after 2 days of the surgery, increasing in nature, high grade fever, then should be intra-articular and go for that.
This is a very not a question. This was a very important aspect, that the infection after ACL reconstruction. So you see, I am working in a government setup where over a period of last 4 years, we have operated around 550 cases of ACL. In the early stages, we didn't have many cases of infections. But of late, what we are seeing, as in a government setup, the care is a bit on a downside. So recently, over a period of 6 months, I've seen almost 7 cases of ACL reconstruction post-op. So I was just amazed what to do. Now I started discussing with different faculties all over India. He said, go for an immediate scopy and try to remove everything which is there inside, any foreign body which is inside. And that was the thing, what I am following nowadays, is 7 cases of ACL reconstruction. I had to remove each and everything, take bits and take everything, the small part of so everything removed. And the red flag signs which we're talking of, many times you find a small bleb formation at the site of surgery. We try to ignore it. Let's see, give some antibiotics, let's see if it can subside. But it is not the case. You need to be very much prompt enough and completely explore the joint, irrigate it completely, remove every foreign bodies, and then plan for reconstruction at second stage later on.
Regarding the prevention of infection, just a minute, sir. To reduce the infection, the concern and the question through the all over the India from the prominent arthroscopic surgeon. The number 1, don't shave that area, just clipping the hair. Number 2, check the sterilization of all the equipment, basically the tendon harvester. Number 3, 1 dose of preoperative antibiotic. Number 4, soak that graft with the 5 milligram per ml of the vancomycin at least 15 minutes. And number 5, try to reduce the contact of the graft to the skin by passing the graft through the tunnel. These 5 points almost reduces your infection rate.
Thank you, Gurudev. The interesting part of orthopedics is that there is no consensus. We will always have discussion and we will continue to have discussion. So it was great session. Thank you all the speakers and my co-panel chairpersons here. And hope if there is any further question, we will continue to discuss more and more. Thank you very much. Thank you. Thank you.
Now I request Dr. S.S. Sir, Dr. Arvind Kumar Sir, and Dr. Nilesh Kumar Sir to kindly share the session. Well, very good morning, and may I request Dr. Ajit to present his paper.
Good morning, respected chairpersons. At the outset, I'm grateful to Dr. Mulia, Dr. Ravneet, and all the organizing team for giving me this opportunity. Small submission. Although the theme is learning from mistakes, unfortunately, my talk is more on the planning and tips and tricks to perform this procedure in a difficult scenario like the pilon fractures. So these are terrible injuries, and there is no consensus regarding the optimal treatment. And often the outcome is quite compromised and the patients may be very unsatisfied with the outcomes. So the soft tissue, like in most periarticular fractures, is the deciding factor as to when to intervene and how to intervene. Planning is very essential and CT is mandatory nowadays. And just like the tibial plateau, the pilon also, we have got classification based on the CT pattern, and also the approaches have been described based on the fracture pattern that we evaluate on the CT scan. So the approaches could be anteromedial, often anterolateral, posterolateral, and occasionally posteromedial as well, as we shall see. But the prognostic factors would be the wounds and the bone loss, and in particular the cartilage loss that happens with this sort of fracture. So we have to be prepared with all the gadgetry that we need, the implants that we need, and also bone graft and maybe bone substitutes also. So planning, you have often a large medial fragment, an anterolateral or the Sharput fragment, and a Volkmann's fragment there. So these are the primary fracture patterns that we see, and the approach and the fixation depends on where the maximum combination is. Also, the fibular fracture may take a decision-making explanation. So the understanding worked better after the publication from Sirkin in 96, I think. And depending on whether it was a varus type of fixation fracture or a valgus type of fracture, the implant had to go in that particular plane. However, if it was an axial load, also then you need to plan it out a little more better. So I'll just run through a few cases. This is a 27-year-old man, and you can see that the anterolateral part is involved much more. The posterior part is intact, so an anterolateral approach and reduce. Put in your temporary fixations, check it under CR, make sure your articular congruity is restored, and then go ahead with your definitive fixation. Another more complex fracture, as you can see, and on the X-ray it looks that most of the anterior part is impacted here. There is combination, and also there is impaction of the anterior and central portions there. So the CT gives you an idea as to how far the anterior articular surface is impacted. So you decide on that. Based on that, you decide on how you approach. Again, mostly an anteromedial approach. You need traction. Sometimes you need a femoral distractor to get a good view of the articular surface, and also make sure that your restoration is achieved. Check under CM again, make sure temporary it holds well, and then go ahead with your fixation. Another one, just rush through some case examples, all variable patterns. This, the posterolateral part is also involved. Get, scan, plan, and plan, scan, and scan, plan, and plan. Yes, that's very confusing. So again, you decide where the fragments are so that you approach it well. So this is from the posterior part. Initially, temporarily buttressed at the back. Then the fibula was fixed and temporarily held from there. The patient was turned over and went on to fix it like that. Ligamentotaxis helps, particularly when there is massive swelling and you have to wait almost 2 to 3 weeks sometimes. Otherwise, sometimes it may be a definitive fixation in very comminuted fractures. So this was an elderly, almost an 80-year-old with just a simple domestic fracture. It looked too low to fix it with any implant, so we put it small fixation there and went on to hold on the X-fix for about 3-4 weeks, and then that was the final picture, external fixator and limited fixation. You can also use hybrid external fixators, as in this particular case. Right, went on to manage this definitively with the hybrid fixator. Of course, not a joint spanning fixator because they have a poorer outcome. So that was the one. And sometimes the articular surface is so badly comminuted that you may find it impossible to reconstruct the articular surface. So you may have to end up with a delayed arthrodesis in this particular thing. The important thing is counseling, taking the patient into confidence, explain to them in detail about the outcomes, and then proceeding with the arthrodesis. So the take-home messages are that these fractures are very difficult ones to manage. Soft tissue, as like the tibial plateau, is the key to success. Often a stage procedure is mandated, and we need to understand the injury by getting CT scans and planning appropriately. Have all the armamentarium with you. You may need combined procedures. Sometimes you may need to flip the patient over from a posterior to an anterior positioning, and the outcomes are often compromised. Thank you very much for your attention.
Thank you, Dr. Ajit. So you have made it aptly clear that failing to plan is almost equivalent to fail. So now for the next paper.
Can I ask a question, sir?
You can do it at the end, or maybe you can do it right now.
Yeah, so Dr. Ajit, you said spanning the joint in external fixator is a disaster or something like that, to that effect you said. Why?
Sorry?
Spanning the joint by external fixator is not a good idea.
No. Definitive fixation. I showed you a hybrid fixator which was managed definitively the case. But there are earlier reports where they managed these for about 6 weeks in a spanning fixator after fixation. That has given inferior results as opposed to fixation or hybrid type of fixation. Plate fixation or hybrid type of fixation. Thank you.
Right, one more question. We will finish the question part. So you have shown one of the X-rays where the distal tibia almost is bag of bones. So what is your approach there?
If the articular cartilage is too badly comminuted and this is a where the reconstruction is nearly impossible, then we need to counsel the patient that in my hands, this is the best I can do. That means you're going to end up with an arthrodesis. If I fix you now, it may be that it will be painful. You would have lost out on a lot of money. So I would just probably put a cast for a while once the swelling subsides, or put him on an external fixator, and in a delayed stage, go ahead and do the arthrodesis, not in the primary stage.
Right. So we also have to be aware that endoprosthesis, which has to be custom made, can be used maybe at a later date. Thank you. Thank you very much.
Now call from Dr. K. Saran for talus fracture.
A very warm welcome to this august audience. I can see many prominent members of the Indian Foot Medical Society, and it's an absolute honor to present my work today. Before I start, just a small trivia. My MS final examination theory paper, 2 p.m. paper. Morning, I'm just going through my books. One of my junior comes and he sees me that I'm going through the talus fracture from the operative board. And 2 p.m. lo and behold, that is the question in my final examination. So Vedant came and said to everybody, he said to the question out there, he was studying talus fracture. So that was the trivia, and from there my love affair with talus has started. So in today's presentation, I'll be, could I have the timer please, so that I can time my presentation. I'll be showing 3 cases. This is a fresh fracture in an adult, comminuted fracture, talus. Second case is a neglected fracture, and I have deliberately kept the name of the patient and especially the age. The 16-year-old girl, a poor girl, who somehow could not see an orthopedic surgeon, and she came maybe 5 months, if I remember correctly, 5 months after injury. I again have another case where there's a grade type, this type of severe fracture dislocation, type 3, and the patient is coming 9 months after injury. So in India, we have these myriad presentation, patient coming at different stages, different presentation, different time. So let me see how let me show you how I dealt with these cases. We know that talus fracture is 5 to 7% of all foot fractures, and most of the time the patient is a young, active and mobile. The fracture could be open also, and 30% of talus fractures are of neck fracture. And mechanism of injury, we know there is forced hyperdorsiflexion of ankle and impingement of the talar neck on the dorsum of the anterior. Classification was given by Hawkins in 1970. I will not go into detail. He gave actually 3 types. The 4th type was given by Kelly, and these are the different types. Type 1 is undisplaced. Blood supply is still intact. Type 2, it is displacement of talar neck with displacement of fracture is there. It will be more than 2 mm with subtalar dislocation. Type 3, subtalar as well as tibiotalar is gone. Type 4, where the talonavicular articulation is also gone. And this has, of course, the first prognosis. So the treatment goal is early anatomical reduction of the fracture as well as all the dislocated joint, stable fixation and avoidance of complication. Type 1, we still can go for a non-operative treatment in a very limited population, but most of the time it has to be operated from type 2, type 3 and type 4. So the surgical management, we need to understand the different approaches, medial, lateral, posterior, but more often than not, Dr. Pradeep would agree, it is a combined approach, is it not? So anteromedial approach is the most commonly used approach, and sometimes medial malar osteotomy is required. In lateral approach, we have to open it, of course, in such a way that the sinus tarsi blood supply remain intact. If we do too much of soft tissue dissection, chances are that we will jeopardize that thing. This also gives a good view of the subtalar joint, but however, there is poor exposure of the fracture site if not done properly. Posterior approach, of course, it facilitates us to put the screw from posterior to anterior, but chances of neurovascular damage is there. Nowadays, with high velocity trauma, we have to use a combined approach in which we use the medial approach and as well as the lateral approach. Now, fixation methods. The age-old simple screw fixation is there, or more recent special plates, or sometimes plates, the mini plates, which we use for fixing metacarpal and metatarsal. That will also be in a way fashioned, which I will show in my cases for this fixation. So screw fixation could be anterior to posterior, posterior to anterior. They have their own advantages and disadvantages. For the sake of time, I will not go into detail, but there was a study, very interesting one, and recently as in 2020, where it was shown that the screws which are put parallel and posterior to anterior, they have the maximum strength of stability. So if we are relying on those screws only, the screws are better put posterior to anterior. But then putting the screws anterior to posterior is better. So yes, it depends upon your setup, your methods, your ease with which you can put the screw. All these factors has to be taken into consideration before you decide how to put the screws and where. Now, plates. Now, plates provide a stronger fixation. But if not done properly, that may lead to extensive soft tissue dissection, which is really harmful to the overall outcome. Of course, we can have open fractures also, which will require devices which are used for all open fractures. These are complications, but let me come to the case. Now, this was the first case which I showed, and here we have used the plate. This was a mini plate because of the price constraints and availability constraints, this was used, and this was the second case where it was neglected. We did medial malenostomy, exposed the fracture site, freshened up of all the soft tissues, including soft tissues as well as the bony ends, and then we put screws to fix it. And these are the follow-up X-rays. We can see that I was probably lucky as well as was the patient. We could achieve a good result. So this is a follow-up of 8 months. Now this fracture, not very uncommon in our setup. What we did osteotomy from both the sides, and then these are the results. The patient is able to walk, albeit a little gingerly, and she can also squat. So the take-home message is have a good understanding of the anatomy and identify the fractures, and every cases are to be dealt with in a tailor-made fashion. Thank you so much.
Right, thank you very much. Can we have 2 questions right now? Yes, please.
My question is, how you manage the fracture in children, 6 years, 7 years, they have fracture types?
So they have also to be managed on the same lines. Depending upon their type, they need to be fixed in a stable sort of fashion. That's different.
I used to do, I used to take it to wires, to small means thick wires, 2K wires. I put one from the anterior side and another from the posterior side. And just by the exact manner, I reduce it and then just forward it.
Open or closed, sir?
Closed. Closed.
But then you need to ensure, sir, that your reduction, your osteosynthesis is perfect. If that is not there, chances are that it will land into non-union.
I do under the when I got a great angle, I just forward that wire from one from anterior side and one from posterior side.
I
got
still,
very good results.
Thank you, sir, but I will still advocate an open reduction.
Right, and you have already pointed out about the advantages of putting it from posterior to anterior and anterior to posterior. He has described his own method in which you are putting one from the posterior, one from the anterior. Right. Well, in your extensive experience, have you encountered avascular necrosis?
So by no means my experience is extensive, however, it's so kind of you to say that. Yes, sir, I do have encountered avascular necrosis, and they are not very uncommon. Unfortunately, they do occur. But if my fixation is perfect and with a little persistence, many of the avascular necrosis, they resolve actually. That's a good thing.
So your weight bearing post-operative protocol?
Yes, sir. I have to wait at least for 2 months, 8 weeks before I really start weight cutting.
Dr. Monat.
Excellent cases, Kumar. The last case which you showed, I don't know, I missed the X-ray or something, but with that talus out for such a long period of time, we expect that that would be a vascular fragment. Now, when they go in an AVN, would you still wait and watch, or would you do a hindfoot fusion or an ankle with a subtalar, or how would you manage that?
That's a very good question. I was just waiting for this thing. Allow me some time for this answer. First of all, the rationale behind why I put it back in position. The rationale was, even if it doesn't unite, I still have a bone blocking position to do some kind of arthrodesis. It could be a TTC nail or any other nail. So putting that back in position was imperative, number one. Number two, you asked whether I persist, or maybe your question was how much time should I wait? Yes. Chances are that it will land into AVN, and the sooner I identify that AVN and do a hindfoot fusion with calcaneus, because the blood supply is from the low up, and it actually helps in resolving the AVN. So this is what I do.
Right. Well, we will discuss this point, very useful point that you have brought up. And I would like to mention that in any situation, when you feel like that this talus is not working, is a painful foot, it will require replacement. And the Japanese Takakura total talus replacement is now being done. World. So we just have to be aware of it. Any comment you would like?
Yeah, leave a comment.
So, I was with Hinterman just last 1 month back, and he's been doing total tailor replacement. I know it's a new thing in the vogue. People have been doing it in India as well, and there's a series by Cindy Farik as well. But his take is, what happens, he's been doing since 1995, total tailor replacement. And he's taken them a lot of things out. What happens after 5 to 7 years at total tailors doesn't work? Then what do you do? Think about it.
Right. So we always have to be thinking more about the complications.
Let's do that. I'm also going to Hinterman next month. So I'll ask probably.
Thank you,
Anyway,
Dr. Anand.
yes sir, before we end, I'll just request and exhort everybody to come and attend the IFASCON 2023 at Nagpur, where a nice amalgam of all the stalwarts are coming. Thank you so much.
Thank you, Sandy. Next speaker is Dr. D.P. Bhushan. He will talk about the ECO.
Just one comment on the.
Dr. Bhushan? Sir. He starts, Santanu, your take about players fusion?
Yes,
Your experience with the players?
So player fusion is a very nice procedure, and it has its place in our armamentarium, is still there, and we do it. Yeah,
So
absolutely.
you are happy with the results?
Yes. Yeah. Sir.
So the retinoid ligament, fix or ignore or fix. So this is pointer.
Yes, sir.
So first we should understand the retinoid ligament. This is superficial part and this is deep part. Superficial is calcaneal, the spring ligament and navicular. It's a triangular, therefore it's retinoid ligament. And deeper is anterior tibio-talar ligament and posterior tibio-talar ligament. From posterior to anterior, the ligament becomes weak. The PTTL is the strongest and the most consistent thing. In many cadaver studies, it has been found to be 100% present, and ATTL goes down to 64%. So 100%, 90%, 100%, 90%, 70, 80, and this comes to 64%. Second thing, besides its presence and besides its strength, the jaw. The posterior component, here and here, this thing, these two components are there to prevent the varus and valgus strain. Whereas these, they give way in inversion and eversion also. So the type of injury which goes and hits them is to be understood. Acute deltoid complex injuries occur along with the ankle fracture, we all know. Individuals and PER and SCR and abduction, these things are there. And with SCR, there is type A and type B. Clinical features, obviously we have to suspect it unless an MRI is done. Pain, swelling, tenderness on the medial aspect of the ankle, bruising that may spread to the heel, popping sound at the time of injury, unable or difficult to walk soon after the injury, and children who are very resilient, they are not able to walk for the first 4 steps. Investigation, standard radiograph, can miss the sudden deltoid injury unless there is a chip. A stress radiograph, there is a manual or a stress gravity view, and there is a weight bearing view. Fluoroscopic analysis, a stress maneuver, that is inversion, lateral translation, and external rotation. Of course, nothing to say about the MRI and CT, that goes without saying. So MRI, as you can see, this is 80 TL. The spring ligament, flexor retinaculum, tendon, spring ligament here, going up to the TSL. This is another level. These are two deep ligaments, and you can see this is a thinner ligament and this is a thicker ligament. Constant, the strongest, and the most important for the stability. And they are the two tendons, retinaculum and iliospring ligament. In CT, these are indications of deltoid ligament rupture. Why to repair? It prevents non-anatomical healing of deltoid. That is there in all the ligaments and all the bones. Then the loss of peritalar stability, as you see in the rings, 1 or 2 breaks, medial ankle instability, medial ankle pain, increased risk of ankle arthrosis, and valgus related deformities. Why to repair? Standard treatment protocol is approximation of anatomical fibular length. This is the first thing we all learn, we know, we do. Restoration of ankle motus as told by your Ajit. And rigid fixation, there are many plates, tailor-made plates, anatomical plates. Long-term stability depends on appropriate balancing of osseous and ligamentous structures that has been taught in ankle, and the whole ankle stands on that. It must heal with adequate integrity and tension. So, when to repair? Assessment of instability preoperatively, intraoperatively, and after the fixation is to be done. As you can see, this is simple stress test, this is weight bearing or squeeze test, this is a gravity test. As I have told you, that if you are doing gravity test, the foot is plantar flexed. If the foot is plantar flexed, the posterior deep ligament is also relaxed and anterior is more relaxed. And you see more of ankle opening even more than 4 mm, 5 mm, 6 mm, whatever the parameter or cutoff line. But once it is dorsiflex, this way or this way, or even the weight bearing X-ray is there, then the same 4 mm, 5 mm is reduced to 3 or 2 mm. This reduction of the joint space narrowing or joint space widening on the medial side, MCS, at the level of the talar dome, this shows that once the ligament is tight, the joint space is maintained. And this is SER4A, and if it is wide in both the views, it is SER4B. Surgical treatment determined by the fracture pattern, location, displacement and pattern, repair of the serous muscles of injury first, and open primary repair. Complete deltoid tear, mid-substance tear, or avulsion of deltoid from the talus, it should be addressed according to its own tear. Arthroscopic repair can also be done especially in the comorbidities. Open primary repair, incision, a curvilinear, go to the reverse posterior tendon, cut the sheet, push it, the ligament is in front of you, and do whatever you want to do. Second thing, somehow if you have to repair it, you can use the suture, you can use the stitch with the periosteum, or you can make a drill hole and pass number 5 ethibond, or tape-like structures in the complete disruption of the mid-substance tear, or there can be a direct primary repair with a suture if it is very lax. Hardware for the associated medial vellus fracture many times it helps. Arthroscopic repair, obviously I told you. Controversy in primary deltoid repair. No consensus on the optimal treatment or preferred operative treatment for acute deltoid ligament injuries during the ankle fracture fixation. No consensus. Once again, no consensus. Historical trend is fibular fixation with addition of syndesmotic screw, and many times we feel that these two things, once done, the MCS will not open. And the recent trend towards fixation is primary repair of deltoid, syndesmotic fixation in order to restore and maintain the stability of the ankle motis. And there's an article of Lee. It says that you fix everything, stress it. Stress it. If you see more than 7 degrees tilt, there is definitely a need for the deltoid ligament fracture fixation. So, this is an article, a recent article. This shows only one thing, that once in a while we need a fixation. And there had been meta-analysis also, and we see they say that there is no difference between fixation or not fixation. But I think if we stick to 7 degrees principle, we'll be able to do the justice to the patient, and probably we'll be immobilizing less and less. There had been a tendency not to fix it just for one reason, that is very vascular to the middle side. Whatever you do, it usually takes care of itself. But if it is gone inside, curved inside the middle malleolus, it should be taken out and it should be fixed. I heard the monarch's this, and he has also stressed on 7 degrees angulation in his own case, which I have shown. Besides, I request all of you to join a newly formed state chapter by the previous secretary of IFAS, Dr. Shantanu. He is the founder, secretary general of the first state chapter of Foot Society, that is Bihar Jharkhand Foot Society. And I think if we start it, the other state societies will also turn up. Kuchakar has also promised that we will start a Goa society. So we are going big, we are going large, and the foot is not only foot, it is a big foot. Thank you.
All right, thank you. 2 questions from the audience. Any questions? Well, till the time there is a question from the audience, Dr. Pangan. When you decide you have to ignore it, what is your plan then?
Sir, once we fix the ankle joint and we don't find a very important gap, MCS is always taken care of by syndesmotic fixation. The tilt, it is again controversial. The Leon has done कि नहीं करना है, लेकिन actually it's not there. And worldwide they have not accepted it. But if there is a tilt, I will like to fix it. एक और 2 stitches तो मारना है sir. And if I feel that it has incurred, then I would like to open and see it at least. If it is not inside, I can leave it or just do a couple of stitches. Or if it is an old thing, then of course I will post it.
Right, thank you.
Yes, please. That's what I am telling you, sir. I have a video also of arthritis, the way they have repaired it. There are 3 points as I have shown it. Those 3 points are to be remembered. 1 point for the deep ligament, 1 point for the superficial ligament, and 1 point for the medial malleolus. Medial malleolus is fixed. For the talus, there is a point where ankle should go, and in calcaneum, on the sustentabular metalli, it should be there. If these 2 points are fixed along with an interval point, it usually is taken care of. Fibrosis always occurs, but the anatomy should be restored. And it should be confirmed by tilting as well as MCS.
Your post op is just like an acute here.
Yes, sir. Post op is just like an acute.
Thank you, sir. Very nice presentation.
Thank you very much.
Next speaker is Dr. Pradeep Munat on approach to distract.
The one point while setting it up, except probably of the deltoid, I would want to suggest is once you have fixed thing I would suggest to do is, and I think very nicely pointed out by Sir, is the difference between gravity view and weight bearing view. And I cannot stress that point enough, because a lot of times in our discussion, every time in any of the WhatsApp group, everybody says, take a gravity view, take a gravity view. If you just rely on the gravity view, one is your incidence of surgeries will increase. Okay? So you always take a weight bearing view. And second thing is, after fixing the fibula, there are two ways you can do it. You can check that if you want to do a syndesmotic fixation, or would you like to go ahead with a deltoid fixation. Those are the two different things.
Any problem that the next speaker we can call?
Dr. Monar's paper comes out. Many times during rounds, our postgraduates always ask, what is the cause? There is a very less incidence of primary osteoarthritis of ankle in comparison to the knee or
Thank you very much. Sorry for the delay.
Go ahead, your time starts now.
Okay, thank you so much. So I'd like to thank Dr. Namalya Singh and the organizers for inviting me to such a lovely conference. Aim is to talk about the management principles of Lisfranc, which is a very important injury. These are my objectives. So just a brief thing, 30-year-old female starts, has a minor fall from stairs, diagnosed with a midfoot sprain. Treated as a fracture basement metatarsal, 6 weeks in plaster. Comes to me 3 months later with this kind of deformity. This was the X-ray 3 months post-injury. So what went wrong? It was not taken as a weight-bearing X-ray and they missed a Lisfranc. Why is it important as a Lisfranc? Because if you miss a Lisfranc, they can cause chronic pain, function loss, and a deformity. And the most common deformity is usually a flat foot. Looking at the anatomy, usually 3 units or 4 units, however we may describe it. The first is a stable unit, but it has a degree of movement, that's 6 degrees. The second and third TMT joint does not have any movements, and then the lateral force effects are mobile. Lisfranc ligament, I'm sure everybody is aware, goes from the on the plantar side, usually from medial uniform to the base of the second TMT, and there are 3 different parts. The most important is the interosseous and the plantar aspect. I'm not going into the detailed anatomy, but learn to see in your axial views this image on the MRI, because this is where you want to see the Lisfranc ligament, and many times if it's a pure ligamentous, the radiologist may miss it, so you should look at that MRI images very closely. Sprains, pure ligamentous, 3 different grades. Mild pain, swelling, but no instability. That means no opening up of your C1, M2 area. That's stage 1. Stage 2, pain and swelling is more. Ecchymosis may be there, but no instability. And this is where you want to pick up these kind of stage 3 or grade 3, where there is pure ligamentous, but there is opening up of C1, M2 area. And it could be more than 3 millimeter in diastasis. Physical examination, any patient who comes with a midfoot sprain, in my books, it is Lisfranc unless proven otherwise. And I really need to work up this patient to disprove that this is a unstable Lisfranc. Pain and swelling, big lump in the midfoot area, unable to weight, tenderness along the TMT joints. These are all classical signs of Lisfranc. Always have a habit of looking on the plantar aspect of the foot. If you see this ecchymosis, that's a telltale sign of a Lisfranc. Also learn to do a piano key sign, which is hold the metatarsal head, usually the second metatarsal head, and move up and down, and the patient will complain of pain in the middle part of the foot. That's again a list frank. X-ray wise, learn to take AP, lateral and oblique. A 30-degree oblique are mandatory. And learn to look at those signs, which I'm not going to go into the details because of the lack of time. But this new sign is there. Something called as a notch sign, which denotes a medial cuneiform rotation. That means a may or may not be present with a C1M2 whitening. This is in comparison of the right and the left side. The left side, you can see the medial cuneiform is slightly rotated, suggests a interior cuneiform instability. On a lateral view, check if there is a dorsal subluxation as well. Now we are not looking on the radiographs to pick up these sides. These are very obvious. This is Lisfranc. What you want to pick up is the subtle Lisfranc in your day-to-day practice. So you want to see stress views. You can do is some first thing is learn to do a stress view is your weight bearing view. Here again compare on the left and the right side. The right side the C1M2 is opened up and the loss of the line is also there. You can see. Any additional imaging, yes, you can get it done. You can take the patient to operation theatre and take a fluoroscopy. In Mumbai, probably may be better to do a surgery than to take the patient to OR. That's that expensive. Get a CT, MR, or if suspicious, wait for some time, call the patient back in a week's time where the pain is less, and you can get a weight bearing X-rays. Now, in the management, key is whom do you consult and whom do you operate. The goal is to make the painless, plantigrade stable foot. Check for instability. So if there is anything less than 2 millimeter gaping or a shift, or between the first and the second metatarsal, the gap or diastasis is less than 2.7 millimeter, it is considered as stable. Again, as I said, you need to prove that it is less than 2 millimeter. If it is the case, 6 weeks of plaster non-weight bearing, and after that another 6 weeks of weight bearing plaster. So effectively 3 months of immobilization. If it is planned for surgery or if the diastasis are more than 2 millimeters, then the surgery is the requirement. Key thing is to get an anatomical reduction. Now before you put your knife to the skin, the first thing you need to prove again on the CR is which joints are unstable. If it's first, second, only second, first, second, third. Now the reason is you would want to plan your incision accordingly. If it is all the 3 medial rays, then the first incision will be on the medial side and the second will be between the second and third TMT joints. That's why it is very important how you plan it. Now here you can see this is the second and third instability. So you take your incision, put your periosteum, and then you can see how the instability is seen between the first and second. The first thing is reduce your second TMT joint, hold it with a clamp and then check to see that there is a no step and the reduction is perfect. And here you can see how that second TMT has sat nicely into the notch. That is what you want to see, both visually as well as on X-ray. Once you have done that, you can pass a guide wire from the base of the second to the medial cuneiform. Just hold it there, then check for the first TMT and check for the other joints which are unstable, and you can reduce them. Proceed with the permanent fixation. The first is a Lisfranc screw, goes from the base of the second to the medial cuneiform. It's easy to aim from a smaller bone to a bigger bone against a vice versa, which was usually done historically. So that's what you won't want to do. And these are positional screws, not a lat screw. Now in front of a few of my X-rays, I have done a partial threaded again because of the unavailability of a just a few more minutes. So do that, and if there is an intercuneiform instability, please fix that as well. Second TMT joint is then stabilized or neutralized with a plate. If it is a medial column instability, again that is also stabilized with a plate. I do not use transarticular screws. Once you have done your first, second or second, usually the lateral metatarsals come and reduce automatically. You can fix them just with a K wire. Now, do transarticular screws are better or a dorsal bridge plating? This is a nice study from JPJs or the PJJR, which has compared 108 patients between transarticular screws, dorsal bridge plating and combination technique. And what they have found is a better functional outcomes with bridge plate functional outcomes are dependent on the quality of reduction. And of course, more the columns involved, worse is the outcome. Okay, that's because of the degree of injury. And they concluded that it is better to do plating than transarticular fixation. So these are just few examples of how you can do bridge plating in different configuration. Just last one or two more slides. I will not go to the other example. Now, pure ligamentous injury, we knew the fact we should be doing fusions or primary arthrodesis, but now the trend is towards a flexible fixation. Either you can use a tight rope or an internal brace, which has shown a superior option while also maintaining the joint mechanics, and unnecessary of future or further surgeries are not required. Cases wise, I'm not just going to go through that. Just one case I may just do it. This is a patient who came 6 weeks after the injury, pain in the first TMD joint. Okay, though you can see that the second TMD is not aligned properly. Sorry, this one. Second, this is again first TMD joint pain. Second TMD is not aligned. Got a weight bearing CT scan done. We had that option in Mumbai, and you can see the first TMD is out of line, and that is what if before the surgery. Check for the CR. You can see the first, second TMD are not stable. Check. Look at this. There, you can see the first TMD and the second TMD are unstable. There is a gap. You can see that the size of the hemostat, that is a gap present, and after fixation. So post-operative protocol, I usually keep them in a slab for 2 weeks. Weight bearing is started at 3 months time. If the hardware is spanning through the joints, I remove them at between 6 to 8 months mark. Excellent results are found in patients who have done anatomical reduction. If you don't have that, your reduction or your outcome is fairly or significantly compromised. So in conclusion, these are commonly missed injuries. Please suspect this frank to patients who diagnose as midfoot sprain. Investigate them appropriately, and most of the time, if you see a diastasis, invariably these patients need surgery. Fantastic lines by Les Frank himself. Surgery is bright when operating, but it is still brighter when there is no blood and mutilation, and yet leads to the patient's recovery. Thank you very much. Sorry to take a little bit more time.
So, thank you very much. Well, this fracture is important only because, hello, this fracture is important only because you have rightly said they are usually missed. And whenever a presentation is missed, further awareness is created that it is diagnosed. Once you diagnose, there are surgical and non-surgical means. Well, I'm apprehensive. Only one question from the audience. Yes.
While the presentation is by Manoj, I'm sure there are going to be 10 questions at least, but since one question is there, my question is, Pradeep, how important is the inter-uniform instability, and per op, how much of weightage you give it?
If I see there is an increase in the distance between the medial and the intermediate uniform compared to the other side, I would fix it. Okay, and that is very important to suggest. And also, I would fix it before I put my list frank screw, because if you once you put your list frank screw, then putting an inter-uniform screw, the whole construct, you probably technically you are jeopardizing the construct. Now, I don't think so. There is any study looking at which fixation should be done first, but that just seems logical. But if you suspect there is a widening gap, put an inter-uniform screw.
Right, thank you.
Thank you,
Friends, I would just like to mention that one method of treatment could have been elastic adhesive strapping in some of the non-surgical patients, and unfortunately we are not in the habit of treating our patients with strapping, but we should induce our juniors to do that. That also is a good matter. Thank you very much. Next presentation. Arvind?
Elizarov in conditions of
Excellent presentation.
Good morning to one and all. I thank Amudya sir and team GOFCON for giving me opportunity to talk on applications of Elizabeth foot and ankle. There are various applications of Elizabeth foot and ankle, be it a congenital or developmental or infection, trauma sequelae or tumor or post-burns contracture or amputation stump lengthening and miscellaneous. Most of the cases which I have done I have put, but certain cases which I have not done I have picked it from the books. So what are the advantages? It corrects the deformity. In fact, we can do overcorrection which we cannot do it with acute correction with a nail or a plate. And this reduces recurrence. We can correct the deformity as well as we can lengthen it. And it's very minimally invasive. In fact, the osteotomies also can be carried out with small incisions. So there are disadvantages as well, but as well as complications associated. We all know the complications of external fixator. But when we are handling the cases of foot and ankle, these are the cases with advanced stage of foot and ankle diseases. So they come to us as a last resort. So we have more advantages than considering the disadvantages of the fixator. So let us go through the case. This boy was a neglected CTEV, 13 years old. So I went ahead, applied the fixator, initially only to stretch or overstretch the soft tissues. I could easily correct some part of the forefoot adduction, but the equinus deformity remained. Then I went and analyzed again, he had a flat top talus. Again I counseled the patient and proceeded with V osteotomy and corrected the deformity. So before we plan a fixator in any case of foot and ankle, we are supposed to plan the hinges placement, which is very important. And in this, we can see here, one hinge has to be placed on the superior aspect here of the V osteotomy, another hinge at the inferior aspect to get the calcaneus posterior aspect down, and another at the superior aspect here. This is the corresponding hinge of the anterior and superior and inferior here. So over a period of time, the child was very cooperative. I got a beautiful correction of the V osteotomy, and this is the clinical picture. Now I have put him on a slab. Recently I have taken out the fixator and I have put him on a slab for the pin tracks to heal. Now I will not go into detail of the theory part. So we have to remember the number of wires we are supposed to use, and angle of wires and position of olives, and how exactly we are supposed to divide them. Now the frame has two sections, leg and a foot component, and planning of hinges, especially in deformity correction, is very much important. Another application is transverse tibial distraction, which I have applied in one of my case. This was a lady of post fixation of the charcoals and post implant removal. She had a very big raw area on the dorsum of the foot. So I went ahead, took a plastic opinion. They told nothing can be done for this lady because all her arteries were atherosclerosed. So no flap was possible in her. Then I went, I counseled the patient, did a fixator in this aspect. It depends on the surgeon to surgeon again, and did a transverse tibial transport, which increases the vascularity by around 10%, and this has given me very beautiful results. This can be tried for any kind of diabetic foot ulcers also. Another case of mine with post-infective sequelae, we can see the valgus of the pylon, physeal arrest of the lateral malleolus, post-infection of the lateral malleolus in childhood. So I went ahead, did osteotomy rule 1, open wedge osteotomy, fixed it with a graft. Then supramalleolar osteotomy for the pylon correction and gradual opening up of the osteotomy. He has really achieved very good correction in this case. So this is the video of the patient walking. We can't make out which side he was operated. Another application is arthrodesis. This was one of my case of infected Charcot's arthropathy with hereditary sensory motor neuropathy. Lady was in fact referred for amputation, but I counseled her. I went ahead, debrided properly, put a fixator on and started compressing. The wounds healed well, the sinuses healed well, and she has achieved very good union at the site. She is walking independently without any support. Another lady, Charcot's subtalar dislocation, E. coli heavy growth. So I went ahead and planned my hinge placement using osteotomy rule 3, and she achieved very good correction. Here you can see the calcaneum is almost got back to its normal place. Then I went ahead, did arthrodesis. It went on to heal well. Another application is mini fixator, which we don't usually do. We put intramedullary wires, which may not help in metatarsal fractures which are comminuted. You can go ahead, put a just fixator or a mini external fixator, and you can get a very good reduction and which can maintain the parabola. Another application is infection. This lady had a tuberculosis of the navicular bone. I went ahead, distracted, and kept the first ray length. And next stage, I went ahead and put a fibula strut graft and completed the arthrodesis. Trauma, we all know, pylon fractures. This person had very bad soft tissue condition. I went ahead, put fixator. It went on to heal really well. Another application is malunion. I went ahead. This was a schizophrenia patient, and but still he was very cooperative. He did the correction really well, and I achieved. Another application is joint distraction in ankle arthritis. There are various. There is a concept stating that the severity of arthritis may not correlate very well with the clinical symptoms. So we can try joint distraction treatment in case of ankle arthritis. So there are studies which state that the function, clinical condition and mobility improves after this. Another application, metatarsal lengthening, but be careful when we are handling post-traumatic shortening. The soft tissues may not heal very well. Yes, sir. So, take-home message will be, it's a versatile tool, it can be used in various conditions, proper planning is necessary, and it needs a learning curve. Thank you.
Right, thank you very much for a very lucid presentation, and definitely Elizarov has a place in foot deformity correction. One question? Yes.
Excellent cases, I'm really spellbound actually. However, the cases of Charcot, they are really difficult to crack. So the two cases that you showed had an excellent result. So what is your overall experience with Charcot foot? Are they all these successful, or you still had your share of failures?
I had, sir. Especially in case where the talus was not there at all and the upper part of calcaneus was missing, including midfoot. When they come at very late, I had to really fight with that case to get some union. Especially when they are infected and MRSA positive, they have not given me very good results.
Right, thank you very much. It's a challenging problem. Santanu has really pointed out well. Good.
Our next speaker is Dr. Vinay Kumar Singh. In talk on ankle fracture, get it right first time.
Okay, good afternoon everyone, or good morning, I think it's still morning. Many thanks for inviting me to this prestigious GOFCON conference. I would like to thank Dr. Zulia for inviting me here. Now, continuing with the session, we'll talk about foot and ankle fractures for the next 7 minutes. And hopefully, we'll try to see what we can do so that we don't have the complications. Now, as you all know, ankle fracture is quite common. We have all dealt with ankle fractures in orthopedic surgery. And 14% of trauma admissions, especially in Western world, are related to ankle fractures. Now, when you operate on ankle fractures, or any fracture, or any operation, you have some risk of, you have some complications. So the commonest one is infection. Now, infection rate in ankle, in a straightforward case, is quoted up to 3.4%, and in patients, if they are diabetic, it can be up to 20%. So infection is much more than any other extremity or any other trauma situation that we usually do. And despite doing a very good job, around 38 to 40% of the patients, they don't go back to playing sports. So it can be a career-ending injury, or once you have an ankle fracture, it could be end of a normal gait pattern, or you could be left with some residual swelling or some pain for the rest of your life. So if you have an ankle fracture, if you have an opportunity, get it right first time. That is true for every fracture, but I think it's more so apt for an ankle fracture. So when you are seeing a patient of an ankle fracture, as soon as you have a patient, of course, you need to take care of the pain, give patient appropriate analgesia, apply splint. You know, splint and elevation may sound like a very small thing, but it helps in keeping the swelling down and keeping the area, the soft tissue envelope healthy, so that you are able to operate early. If you have a fracture dislocation, try to reduce it early. Don't wait for the X-ray. Reduce it, splint it, keep it elevated, so that you have got opportunity to operate at an earliest. If you have an open fracture, of course, it goes beyond saying that you have to look after the wound, give early antibiotics, and neurovascular assessment is imperative in any orthopedic injuries, and it's also important in ankle fracture. Now, few conditions that you should be very, very mindful if you are dealing with ankle fracture or fracture around, lower extremity or around calcaneum is diabetes, peripheral neuropathy, peripheral vascular disease, renal disease, smoking and alcohol. These are the red flags, and these are the patients. If I can opt for non-operative treatment, I will try to avoid surgery in these cases, because you don't want to burn your hands. And if you want to burn your hands, and if you have infection, this could lead to an amputation and an adverse outcome. So once you have seen the patient, even primary aid, you need, orthopedics is all about X-rays, but getting the right X-rays is important. So the common X-rays that I would do is an AB, mortis, and a lateral. These are the three X-rays that I would do, but there is mention that you can get oblique. Whenever you are in doubt whether this is a stable or unstable injury, whether the deltoid ligament is gone, then you may require manual stress view, gravity stress view, or weight-bearing views. And we can talk about it, which is better or which is not as good. But in my view, I usually use gravity-assisted view. I understand there was a speaker before me who said that he was slightly anxious about doing it, but this is my free practice, that I would get a gravity stress view because it is less painful and it gets me the information that I'm usually looking for. CT scans, of course, has got a role. USG MRI, in my practice, in my 20 years of practice, I've never used USG, I've never used MRI, but there are some certain recent papers where they talk about if you want to find out about ligament injuries, you can use MRI, but I think for Indian context, I have never used it, ultrasound MRI, but it is mentioned. So this is just a demonstration of gravity stress view. So keep the leg towards the end of the table and take an X-ray. It is less painful, and if you see this opening, then it tells you that deltoid ligament is gone. It can help you immensely in deciding what you want to do. This is the second view is the manual stress view, but I think more and more people are moving towards the weight-bearing views, and I think I would agree with it that weight-bearing views is the recent trend. But in smaller hospitals, it is very difficult to get a weight-bearing views because you need specialist trained people who can get these weight-bearing views, and it's very difficult. So I do a gravity stress view. So normal radiology, I think if you want to talk about normal radiology, I can talk it for 10 minutes or just normal radiology, but these are two or three things that I always keep in mind. One is the talocrural angle. You want to recreate talocrural angle to around 83 or plus minus whatever it is, so that there is no talar tilt, because any amount of talar tilt or talar shift will lead to adverse outcome. The other two important things is the tibiofibular clear space and the tibiofibular overlap. So the overlap should be 6 or more, and the clear space should be same around 5 or 6 or less. So if there is any abnormality, if the measurements are not within normal, think that syndesmosis is gone, and then you may have to address the syndesmosis. Now in terms of classification, this is the most simplistic classification. Working in England, all medical students, they know Weber A, Weber B, Weber C. It's a simplistic classification, but people who don't do foot and ankle as bread and butter, it is still one of the most important classifications, because Weber A fracture, which is below the syndesmosis, tells me that you don't need to operate, you can get them working from day one. Weber B, it tells me that maybe around 50% of them will be stable, half of them may be associated with syndesmotic injury and we may have to operate. Weber C is usually pronation injury, suggesting the syndesmosis is gone and there is a very high likelihood that you need to operate. Now the other classification system which makes people nervous, people who are not doing foot and ankle, sounds very complicated, is the Log-Hansen classification. I'll try to make it simple. The first was describe the position of the foot, and the second describes the direction of the force. So this is a representation of what is supination. Now supination is quite a complex movement of inversion, adduction and plantarflexion, and similarly pronation is a complex movement of eversion, abduction and dorsiflexion. So just picture in this mind. So you can have only few combinations of it. Look at an X-ray and decide whether the fracture is at the syndesmosis or not. If it is at the fracture of syndesmosis, it is a supination injury. And then look at the medial malleolus. If the medial malleolus fracture is vertical, it is adduction injury, and if it is horizontal, it is external rotation injury. Similarly, if the fracture is above the syndesmosis, it is a pronation injury. And look at the fibula fracture. If it is simple fracture, it's external rotation, and if there is a butterfly fragment with combination, it is abduction. So I'll give you some examples. So this is a classical X-ray of supination external rotation injury, because the fracture is at the level of syndesmosis and the medial malleolus fracture is horizontal. On the other side, this is a classical supination adduction injury, because fibula fracture is at the level of syndesmosis, but the fracture of the medial malleolus is vertical. Now, as I said, if the fracture is above the level of syndesmosis, it is a pronation injury. I think I will take a few more minutes. And if it is combination, it is pronation abduction. So now it is, you have to decide what is stable and unstable. For all stable injuries, you put them in weight-bearing plaster or an A-cast boot and get them going from day one, and your default statement should be, weight-bearing has to operate it. Surgical indications are usually for unstable fractures, and they generally include if the syndesmosis is gone, bimalleolar, triangular fracture, open fracture, or fracture dislocations. Now timing is extremely critical. If you are operating on an ankle, try to operate within the first few days or after a week or so. Otherwise, there are many evidence that it will increase the complication rate.
Conclude.
Yeah, I'm very sorry. I'm taking some time. Just to take one slide on principles. The most important principle is restore the fibular length and rotation. Secondly, you have to address the syndesmosis. Thirdly, if there is a posterior malleolus, you need to fix it. And if there is a medial malleolus fracture, depending upon the size, you can use plates, screws, or tension band wiring. These are the common implants. So I'll just end with this one example. This is a classical example of supination adduction injury. So this is what I did. So this is done through a post-lateral approach, where we fix the posterior malleolus, we fix the lateral malleolus, and then put a buttress mode. So all these plates are in buttress mode, fixing the fracture. There are some controversies which are very difficult to address, but I think some of you may ask the question. But take-home message is try to operate on day one, achieve good fibular length and rotation. Anatomic syndesmotic reduction is the key. Posterior malleolus should be fixed. Previously we used to say more than 25%, that is long gone back. You should try to fix posterior malleolus, you should know posterolateral approach. Syndesmotic, once you fix the posterior malleolus, you don't need to use a syndesmotic screw. Most times, one tubular plate will do the job. Locking plate, in my experience, is unnecessary, expensive implant. You can get away 99.9% with one tubular plate. Thank you so much.
Thank you very much. Well, you have rightly coined, get it right first time. And confining yourself to the basic pathodynamics of the injury while assessing the patient and while surgically treating them. One question from the audience, if it is there. Otherwise, you can discuss with him. Call for the next paper, which is the last paper, that is syndesmosis injury management, Dr. Jan Say.
Thank you, chairpersons, and for giving me this opportunity, and really gracious hospitality, overwhelmed by the hospitality provided by the GOFCON team and Dr. Amulya Singh and all the other members. And a real privilege to speak amongst the galaxy of foot and ankle surgeons of India and some of the national leaders. So, come to the point. So, syndesmotic ankle sprain is an injury to one or more ligaments of the distal fibular syndesmosis, and it is often referred to as high ankle sprain. And compared to the more common lateral ankle sprain, a high ankle sprain causes pain most proximally just above the ankle joint. So what causes syndesmosis injury? Your foot is firmly planted, the leg rotates internally, and there is external rotation of the talus. What does it feel like? Well, it's pain just above the ankles, does not settle with rest, and there's a cramping sensation or a dull ache, and it gets worse with exercise or sport. Clinically, compression of the proximal fibula against the tibia, and if pain occurs, then it's positive. That's the fibular compression test, or you could also call it a syndesmotic squeeze test. Intraoperatively, we use what is called the hook test, and you pull the fibula laterally to examine the syndesmotic complex, and you can also do an anterior posterior translation of the fibula by pushing and pulling with your fingers or again a bone hook. Stable isolated syndesmotic injuries can be treated with rest, elevation, compression, and lace-up ankle brace, and followed by resistance and proprioceptive exercises. PRP for such injuries remains controversial, and so does the periligamentous corticosteroid injection. So when does a syndesmotic injury need surgery? Well, when it's a grade 3 complete rupture of the ligament, and this type of injury will require surgery, and recovery time will be about 3 to 6 months. Surgical tips, well, fix the reduction with a 2 mm K-wire from the lateral side distal to the planned distal screw, and 1 to 2 centimeters above the joint line, and the position of the ankle joint during this maneuver should be neutral. Drill a 2.5 mm hole through the fibula and the lateral cortex of the tibia, just proximal to the inferior tibiofibular joint, 30 degrees from the posterior to the anterior, parallel to the tibial plafond, with the ankle in the neutral position. This screw is not intended to act as a compressive lag screw, so the thread must be tapped in both the tibia and fibula. Tap the thread and insert a 3.5 or a 4.5 mm cortical screw. And again reiterating that the foot position should be neutral. Just look at some of the recent literature that we put through. This is on the diagnostic part. And while there are various parameters like the tibiofibular overlap, posterior fibular distance, anterior posterior translation, this study from Korea found out that the surface area of the syndesmosis 1 centimeter above the tibial plafond compared to the uninjured side was the most useful and reliable diagnostic method for predicting syndesmotic injuries in ankle fractures. So some of the controversies that are present in the syndesmotic injury management, whether to use a rigid plate or screw or washer or a dynamic suture button fixation. This study from Turkey, 69 patients and 3 patients from the fixation school required revision surgery. They had done 20 double interosseous suture endo button, 23 single interosseous suture endo button, and 26 screw fixations. And so the interosseous suture endo button system is at least as safe as the screw fixation technique, and it requires the need for second surgery, and there is no statistical difference between the single and the double interosseous suture endo button. So the single endo button system may be the better alternative. Another study, biomechanical comparison, and depending on how the suture button construct should be placed, whether single, parallel or divergent, and there was no statistically significant difference among the 3 fixation techniques. This This is an arthroscopically measured syndesmotic stability after screw versus suture endo-button fixation in a cadaveric mode, and they had 8 pairs. 4 loading conditions were considered: unstressed lateral hook, anterior-posterior translation, and posterior to anterior translation. And they found out that the syndesmotic disruption maintains coronal fibular stability. Screw and suture constructs, however, is greater or insufficient constraint to the fibular motion in the sagittal plane. So you get a good coronal stability, but in the sagittal plane, the stability is not that great. Level of screw fixation, well, there are 2 studies. One says about 3.5 centimeter proximal to the tibiofibular line and the other at a 3 to 4 centimeter above the tibiotalar joint. So some controversy, probably ideal is about 3 centimeters. The size of the screw, well, 3.5 mm and 4.5 mm both work, but probably the 3.5 mm more likely to break. Removal of screw, 87% surgeons routinely remove at 8 to 12 weeks, and another study found no diastasis after weight bearing, and screws were removed, loosened or remained solid and in place. And the third study, Tucker said that screws can be left unless there is stiffness greater than 6 months post-operative. Dynamic fixation of the syndesmosis, unproven and predominantly hypothetical, physiological micromotion, no routine implant removal, and the advantage of early weight bearing. So dynamic fixation of syndesmosis with the suture button outcomes are comparable to the syndesmotic screw, but stability in the sagittal plane and enough stability of the syndesmosis to adequately scar into place and maintain stability remains question mark. Current treatment of choice: arthroscopy to debride the interposed tissue in the syndesmosis, and 2 4 mm quadricortical screws through a fibular plate. This is for the isolated syndesmotic injury. Commence range of motion at 2 weeks, avoid weight bearing for 6 weeks, and pre-planned screw removal at 3 to 4 months. For the syndesmotic injury with associated fractures, or if using various combinations of traditional plate, screw, washer constructs, still remain the recommendation. And at the end of my talk, I just need another minute with the permission of the chairpersons to share what is happening to the medical fraternity in Rajasthan. And this is with regard to the right to health bill, and maybe some of you are aware, but for those who are not aware, it is time for all doctors across India to wake up, because this dragon is going to envelop each and every one of us. Today it is Rajasthan, tomorrow it will be you. So as a representative of Rajasthan, as a doctor, I look forward to your support to this movement where no private, no, complete ban for the last 10 days. There is zero admission, zero surgery in hospitals across Rajasthan. And this is the kind of momentum we have, and we are resisting with all our might. This is a video of what the government does to the doctors. This is on 20th of for people who were sitting on a protest, there was lathi charge. These were doctors.
This is the reward for your corona service.
Yes, sir. There is more reward.
You did a better service during corona. That's why government is.
And the government wants all private hospitals to treat every patient free, irrespective of what is going on.
So what is their government responsibility? What is the government responsibility? They are throwing us on private practice.
We will discuss it when we are there. Our wholehearted support is with.
I just want everyone to be aware that this is the reality. This is happening at our doorstep. It is happening with us, and it is standing at your doorstep. God bless the doctors.
Yes, thank you, Dr. Say. The point that you have brought out about the situation in Rajasthan, I think whole India is supporting you, and maybe we are also coming forward in coming days to be there with you. as far as these syndesmotic injuries are concerned, you have rightly brought out a point which usually is not tackled in the best way. And you have talked about static fixation and dynamic fixation too. Thank you. Since we are running behind schedule, there will be no questions and you are available there for answering the questions. Thank you very much. Well, thank you Dr. Arvind, Dr. Mithilesh for being this morning here. Thank you. Now I request Dr.
Now, this phenomenal increase what I am today. It goes to the organizer, Dr. Amul, and that's very wonderful. So I invite the first speaker, and practicing the spine and emphasizing on spine surgery only. And we have got 4 speakers, Dr. Gautam R. Prasad, Dr. Mahesh Prasad, Dr. Pankaj Kumar, and Dr. Arnab. So the first speaker is Dr. Gautam R. Prasad, and he is going to speak on high-grade village. So Dr. Gautam R. Prasad, please.
A very good afternoon to everyone. Thanks, GOFCON, Amlesh and the chairpersons. So, diseases can be divided into various types like congenital, ischemic, degenerative, traumatic, pathological or iatrogenic. And usually the natural history is the lytic part is more common in boys, the slip is more common in girls. 50% of these patients they will have past defect, and with the growth spurt it actually increases. If they after 16 years, that is after the puberty is totally achieved, usually there is very minimal change. And most of these patients in their lifetime they remain asymptomatic. 90% of the slip at initial presentation do not progress. So if the patient presents to us at more than 20 years of age, most of them are actually stable and they are less symptomatic throughout their life, and these slips are less likely to progress. The high level of activity actually has no role on progression. There are more than a couple of patients of mine who are actually gymnastic, one is table tennis player, and at the age of 13 or 12, we have diagnosed lytic diseases grade 2 to 3, and they are all doing well without surgery. Association with back pain is weak. All back pain did not be because of diseases. So you have to actually figure out why the back pain is, and once you know that, then you plan your treatment. So there are various risk factors, and clinically it's more prominent if girls are more likely to have symptoms. If the back pain is there, if there is postural abnormality, there is dysplastic type of diseases, or there is a vertical sacrum, the slip is more than 50%, or there is increase in slip angle. So these are more likely to progress and more likely to have symptoms. And usually they end up with symptoms because of either the lateral stenosis or the canal stenosis or instability. This instability might be actually dynamic or it can be static in nature. And the presentation is usually in the form of back pain, leg pain, claudication, numbness in the legs, and at times extension catch. So based on your clinical history, your symptoms and your signs, then you actually check out the other parameters like the stance, how the patient stands, what's the gait of the patient, how is the head placed over the pelvis, and how is the hip and knee. So all these things are relevant because, and same things we will see on radiology, X-ray wise, there are various readings, and depending on how the pelvis is present and how the slip is present with respect to the sacrum, you have to grade that. Or one of the most important things is the slip angle, and the other important things are the pelvic parameters. So we should be well aware of this because the PI or the PT is very high. The chances of patient having a unstable spine, unstable back is very high, and these patients usually line up with surgical intervention. Very sagittal parameters, pelvic incidence and the pelvic tilt, they are more important and more correlated with the spondylolisthesis. Another important thing is the axis. of L1 whatever with respect to the S1. So if the distance is more than 35 mm, it's better always to attempt a fusion as well as reduction. Otherwise, the patient might have a high residual back pain post surgery. The management has to be individualized in all the patient. It has to be tailor made, and in that we have to take into consideration all the various parameters of the pelvis, the radiology, the clinical symptoms, and address what is actually leading to pain. So once you decide the patient needs surgery, then the parameters comes whether to fuse or not, whether to decompress or not. So if there is no significant decompression, no significant compression, no focal compression, and the canals is not central stenosis, we can very well manage with indirect decompression by just jacking up the disc space and fixing. So decompression is usually not required in all the cases. And types of fusion. So depending on your approach, it can be an anterior fusion or lateral fusion by OLIF or X-LIF, L-LIF, or from posteriorly we can do a posterolateral fusion or PLF or T-LIF. So depending on your approach, you need to do a fusion. Always keep in mind circumferential fusion is of utmost importance because that takes care of the pseudo-orthosis, that takes care of the pelvis alignment, and that helps in giving a better clinical outcome. Whether to do reduce or not. So partial reduction of the slip and lumbosacral kyphosis has to be done if the slip angle is more. In situ fusion can be done, but then the delta fixation has to be very sturdy. At the same time, while doing the delta fixation, one has to see to that the exiting route is decompressed properly. Reduction maneuver, it is of utmost importance if there is segmental instability or when there is significant sagittal imbalance. The reduction usually has to be partial because the moment we try to achieve complete reduction in high grade diseases, there can be stretching the roots and there can be post-operative neuralgia, post-operative weakness also. So reduction has several advantages like the biomechanical orientation is very well improved, the neurological decompression occurs, the correction of lumbosacral kyphosis and the sagittal alignment is restored. In situ, whenever you do fixation, there is high chance of pseudo-orthosis, and if the reduction is not more than 50%, then we have to address the proximal. Proximal level also into the fusion segments. Usually in high-grade spondylosis, always try to do as much as possible reduction, whatever is possible. Don't try to overdo it because the more you do it, the chances of post-operative neuralgia is present. So this is not a very high-grade disease, but this was done by MIS technique, and this patient was doing very well post surgery. So whether it all depends on your choice, whether you which gauge you use or whether you do in situ fixation. Or this young guy came with a severe listhesis, grade 3 listhesis. This I didn't wanted to fuse the upper normal segment. So what we did was just one level segment T-lift, and there is good amount of reduction. If you see, this is not 100% reduced, but this is good enough to achieve a normal sagittal alignment. And at 3 months he was doing all the routine activities. Now it's more than a year since he has been operated. Another patient, similar thing, good reduction and fusion. This lady, she had lytic listhesis at 2 level. Though at L4-5 there was slight grade 1 listhesis, but it was a lytic one which needed to be addressed, and this was grade 3 listhesis at L5 as well. So the lower one I did posterolateral T-lift, and upper segment we just did in situ fixation. Over suggest. Can I have 1 minute more? Another lady. So why knee and hips are important? So this lady, she had a knee problem, congenital knee issue, and she was severely osteoporotic, bedridden for almost 3 to 4 months. Post-operatively, though we could reduce everything, we lost her to follow-up, and after 7 months she came with a slight fall, and she had this sacral insufficiency fracture. So this was because of the unstable gait that she continued to have. So post-operatively, though she was advised TKR, she refused. She was advised to have regular follow-up, take osteoporotic treatment, which unfortunately was not done because she was lost to follow-up. And then we have to do this segment, a long fixation above and below. So complication will occur. There are complications like chorda-iconic can occur because of root handling or excessive reduction. There can be post-operative pain because pseudo-orthosis, the back pain can be there. There can be asymptomatic adjacent segment disorder. The roots can get stretched. Another patient in which one more complication is there. So this lady had, she was 78-year-old, and what mistake I did, I just did one level fixation, a good relief because it reduced very well. But unfortunately, after few months, she had this again. The screw, upper screws were cut off. Though this was cut off, but her gait had improved, and she could even squat. And after 3 years of this something going wrong, she is still walking, she is still doing all her activities. So what I want to point out is, though you have a bad looking X-ray, the patient had a very good clinical result. So the only thing is, by the time this actually happened, the gauge never moved, and the fusion in subsequent images was stable. So always whenever you see any X-ray, whether it is pre-op or post-op, give importance to the clinical parameters more, and then correlate with the radiological, and then take your decision. So the high criticism. So these are my take-home messages. Thank you very much.
Only one question is allowed, if any. Okay. Next speaker, Dr. Mahesh Prasad. Please maintain the time. Thank you.
Thank you, sir. Our respected chairperson. My topic is standalone cage versus anterior cervical plating in cervical fusion. So nowadays, it is a much more common anterior surgery of the neck in various indications where either trauma or a degenerative disc or certain infective conditions. So my area of discussion is standalone cage is better than the plating. Why? So anterior plating in anterior cervical discectomy and fusion is the gold standard treatment by Smith and Robinsons, and these are the standalone cage. What is a standalone cage? Basically, it is a self-rocking cage in between the two vertebral body. You just fuse it after decompression, and plating is the same thing. So what is the difference? The difference is, it is the zero profile plate. It cannot protrude anterior to the vertebral body, so it is to minimize the post-operative dysphagia and other conditions. Apart from these, certain other conditions has also advantages over the plating. Just discussing. This is the various kind of plate, and the several modifications. So the locking plate, locking standalone cage, it has certain advantages, like the soft tissue dissection is minimal, and to reduce post-operative dysphagia, of course, and profile is zero profile, so there is no protruding anterior to the body, so less chances of post-operative dysphagia. This standalone cage appear to be overcome these indications, and some disagreement like cage migration, loss of cervical lordosis, fusion time is fusion rate is very high in the cases of split. In spite of that, we have a better clinical effect and with minimal exposure time. So plate insertion surgically, it is a time consuming, increased soft tissue dissection, or of course blood loss and surgical time. And hardware related complications like soft tissue injury, in tracheoesophageal lesions and dysphagia is more common in plate. As far as the dysphagia is concerned, it is a minimum in the cases of standalone cage as far as in comparison to the plate. Surgical balance is more common and more strong construct in plating. So both plating and cage improve local and global surgical balance in the single level or a multiple level. And some studies have known to no significant difference between cervical angle between these two principles. So adjacent segment disease is less in our standalone case. So ACDA with a cage only technique, it is a significantly lower rate in post-operative dysphagia, significantly lower rate in adjacent segment degeneration. These two is a very common in a standalone cage. So the technique is better radiographic outcome, significant less subsidence in the case of plating. These two limitations of this our standalone cage. Our experience, I am doing more than 50-60 cases in our Patna Medical College. Both groups plate and cage, and we realized that the standalone cage is most easier to do this in respect of their blood loss, time consumptions, soft tissue section, and of course post-operative dysphagia. So this is the time consuming less in all these cases, blood loss, all this. And I would like to show you some cases which I have done in our institutions, both plate group and standalone case, which have a good results. This is the case of disc prolapse at this level, and the patient having some weakness of both upper and lower limb. And this is the standalone cage insertion, and after 2 years follow-up, and this is the outcome of the patient. You can appreciate the outcome of the patient is fully recovered after 2 years follow-up. Second case, another case, it is a traumatic case. It's a higher injury in between almost C71 level. Very difficult to assess this level anteriorly, and of course we have did a plating in these cases, and this is the 2 years follow-up case, and this is the outcome of the patient. You just appreciate the power of the patient. And our third case, Ajit Kumar Mandal is also had OPLL cases is the higher level, in between the C2 and C3 level, a massive compression at the cord. You can appreciate, and we did it, and this is the CT scan. You just appreciate the canal encroachment, and this is the neurological depth. You cannot walk even, and we did a surgery after corpectomy and anterior plating, and just appreciate the outcome after 1 month. This is just post-operative 3 or 4 days. Another case is a disc prolapse. This is a young lady having disc prolapse at this level, and we did a standalone case at the same level, and we can appreciate the outcome of the patient. Good results. Another case is a traumatic disc prolapse. You can appreciate 5 and 6 level as a neurological deficit, and we did plating. So both of these are having plate and standalone cage and have a good result. But in my series, a standalone cage has certain advantages over the plating, like duration of surgery, blood loss, soft tissue dissection, and of course post-operative dysphagia is much better in this case. So we conclude the ACDF is a gold standard technique, and we use both type of tools as a standalone case or the anterior cervical plating. Anterior cervical plating is a gold standard treatment, but standalone cage has a certain area of concern, is a more important thing like blood loss, dysphagia, and of course incidence, case the incidence. So it is a dependable, safe, and effective alternative to the plating. And further, randomized control trial has to be there for further evaluation. Thank you, sir.
Very well presented. Any question from the audience? I don't think so. The next speaker is Dr. Pankaj Kumar. Topic is cervical dystonia.
Good afternoon, sir. We will discuss the cervical dislocation, mainly the traumatic injury. How to stabilize and indication, and mainly discuss objective of this discussion are identify the etiology, evaluation of injury, and including by imaging technique and treatment management, and the coordination among the interpersonal team. Introduction, the C1 C2 called as axial spine, C2 C7 subaxial spine. Lordosis comes in the C2 C7 area. Objective etiology, evaluation. And younger patients comes with a more high energy injury, and early patients low trauma, usually fall sleep on the ground. Facet joint dislocation can be a purely ligamentous injury. Epidemiology, more commonly common area C5, C6, and more injury due to the RTN, and sometimes physical assault can be visible with a cervical spine injury. And evaluation, how to evaluate? Plain radiography is the first one, later on CT or MRI. When to do CT, MRI is most important. About 70%, 17% of injury occurs in the C7, C1 area. And if you got any injury in the cervical spine, better to do CT around the cervical craniocervical area and assess the Harris rule of 1. If distance from the base of the bastion and the posterior arch and the distance from the anterior arch to the posterior, if it should be more than 1, it means something happened in the cervical occiput area. And subaxial spine, how to get a sagittal X-ray, it's better to visualize subluxation dislocation. Later on CT. Conservative, there are various methods of conservative treatment, and we will discuss about the atlanto-occipital dislocation. This is a serious injury, and CT scan is mandatory, and there are three types: traction injury, distraction, and type 3 is extension, posterior dislocation. More serious is distraction, patient can die on the spot, at the spot. Odontoid fractures, that 3 type, 1, 2, more serious is type 2, more common non-union in type 2. Better to fix type 2 injury or type 3 less commonly. The indication of C1, C2. C1, C2 fixation. Fracture odontoid, non-union odontoid, and posterior odontoid with vascular invasion, rotatory subluxation, rheumatoid arthritis, congenital malformation, and malignancy. C1, C2 fixation. I started with the first with SSY in the early stage of your learning with bone girdle, except bone girdle, later on past fixation of C2, and later on was C1, and subsequent pedicle screw fixation at the C2 and the C1 lateral mass. The best now I am doing only C1 pass and C1 lateral mass and C2 pass fixation, giving the best result and less complication. And we got where not to do C1 C2 fixation. Particular RT injury, particular course of if there is identified course comes into fusion, better not to do C1 C2 fixation. Significant anterior myelopathy, lateral mass fracture of atlas and axis, high grade C2 transverse foramen, and small C2 pass and pedicle. There is summary of posterior surgical fixation. Transarticular fixation with subliminal wire, you will get 100% fixation. And the best one is C1 lateral mass and C2 pass fixation. They technically less complicated procedure and less stable than the particular screw of C2 and C1 lateral mass. Hangman fracture you will get the bilateral pass fracture fixation. Fracture, get a CT, get a X-ray fraction extension. If there is subluxation or dislocation, and fixation is mandatory. If there is no subluxation, treat conservative treatment. I better to fix from anterior. C2, C3 plating. Subaccessible spine, and if there is facet dislocation identified in the sagittal X-ray, anterior plating, ACDF is required. And posterior reduction and instrumentation. When to do posterior only, no anterior. If there is no anterior compression, no anterior, it is better to fix lateral mass or the vertical screw from the posterior. And where to do combined procedure, there is posterior as well anterior soft tissue injury. First reduce anteriorly, later on, and sometimes same sitting, sometimes, and after sometimes if patient condition is well good, then posterior fixation also. And it's a very hypotension should be not avoided to prevent hypoperfusion to the spinal cord. Not always. What is the prognosis? Complete spinal cord injury, expected improvement is ASI grade 1 90% to 20%, and complete recovery in only 1% of patients. Prognosis primarily depends on the neurological status as the first presentation and time of surgical intervention. The better research for the better policy is required, and C1 usually C1 C2 exceptional management sometimes is ventilator dependent and C5 ventilator independent. And the complication, they are the common complaint: infection, vascularity, injury, dysphagia, recurrent limia, border syndrome, pseudoarthritis, segment disease, and deterrence patient injury, cervical dislocation. Patient may be directed by their clinician to see the physical therapist who will design an individual cervical spine rehabilitation protocol, and the physical therapist will evaluate the patient condition to determine the optimal approach to each patient pain and improve cervical mobility. Enhancing healthcare team about the health of faculties and psychologists and interpersonal team. And summary, the treatment of traumatic cervical spine injury can be very complex but also rewarding. Each patient and injury is unique, must be individualized. Fixation, fusion, realignment method are varied and should be on biomedical principle. Thank you.
That is very intriguing paper. Very nice. Now I am inviting a very stylish speaker, Dr. Arnav Sinha. There is a screw everywhere, a screw. A study on misdirected medical screw. Dr. Arnav, please.
Good afternoon everybody, with the permission of the chair. If you look through the CR, if you want to do a distal locking of a femoral nail, you have got a hole in which you need to put in a screw. And similarly, if you look through a CR, look at the pedicle, you have got a hole you need to put in a screw. So there is not much of a difference between both of them. Through the eye of a CR, both of them are the same. But what happens? What about now? This is the danger which lies, which you cannot see on a CR. Despite the improvements in the design of the instruments and the attention to the insertion techniques, cortical perforation of while putting in the pedicle screw does occur. Because many transgressions are asymptomatic, the true incidence is not known. That is a study on the misdirected pedicle screws. Like in this case, there are 6 screws which have been put in. This is the post-op X-ray. Are all of them in or they are out? Is anybody sure about that? We found out that screw number 5 was transgressing the cortex of the pedicle. So we did a study of 140 pedicular screws in the thoracolumbar spine only, conventional open technique using intraoperative fluoroscopy. Post-operative CT was done in all the cases. The percentage of misdirected screws and the complications arising thereof was studied, and also a review of the relevant literature was done. Why did we use a CT? Because according to this study, which used a post-op AP and lateral X-ray in 8 cadavers, the X-ray had a sensitivity of 31% only. According to this study, done with an X-ray, again in cadavers, it showed 73 to 84% accurate placements, and incorrectly labeled correct misplaced screws usually were misplaced medially. This study again, which did a differentiation between using an X-ray to assess our fixation and a CT. There were no neurological deficits in this study, but 28% violated the medial cortex. Definite or questionable violations of the pedicular cortex if you use a CT or X-ray, the discrepancy is 10 times. So in this study, inclusion criteria was all adult patients who underwent posterior spinal fixation at the thoracolumbar spine, regardless of the etiology of the surgery.
Exclusion criteria: cases not having a post-operative CT evaluation. This was a patient factor and limitation. Many of the patients didn't want a post-operative CT to be done. Another exclusion criteria was cases not having post-operative CT evaluation with a detailed description of the grade of the screw perforation. That is the radiologist practice. We found out many radiologists didn't want to participate in this study doing this kind of description of the screw perforation. Again, scoliosis cases were excluded and cervical spine fixation were excluded. Outcome measures were accuracy based on correct cortical breach, frank penetration, again divided into grade B, grade C, grade B, grade A, grade C. Why 4 mm was used? In this criteria, the question is why grade C was greater than 4 mm. Why was 4 mm used? Because it has been shown that the medial pedicle perforation more than 4 mm may endanger foramina. Although there is not strong evidence in literature ensuring violation less than 2 mm is safe, most surgeons consider it as a safe zone of pedicle perforation, that is 4 mm perforation. This study, interesting study, it used a CT in cadavers. They concluded that the accuracy of titanium implants were greater than cobalt chromium screws, thought to be due to less CT scanning artifacts. Interestingly, there was no identifiable correlation between years in clinical practice and accuracy, suggesting that greater experience does not lead to improved accuracy, according to this study. Now look at these X-rays, all the screws are in, everything is alright, or we can say that the second fixation, second level, one of the screws is outside the cortex. This is the CT picture. We can see that all the screws have violated the cortex anteriorly. The results of our study, indications of surgery were varied, which was also a limitation of the study, mostly traumas followed by spondylolisthesis, degenerative diseases and 2 cases of tumor. This was the accuracy, this is the result. This is the grading according to the frank penetration, severity and the complications. As we can see in the complications, correct by 56, frank penetration by 40, mostly medial, mostly grade B penetration. Complications attributable to this misdirection were 8, out of which 4 were medial, 4 were lateral, but thankfully all of them completely resolved with time at subsequent follow-up. One important finding seen in literature was that the screw positioned with a free hand technique tend to perforate the cortex medially. The screw placed with CT navigation seemed to perforate the cortex laterally. Normally, if the unintended perforations using CT navigation would have been the result of the inherent inaccuracy of the navigation system, then the perforation should be randomly distributed medially and laterally, but they were more perforated on the lateral side. The explanation could be the difference between the longitudinal midline axis of the pedicle and the anatomical feasible axis. Sometimes, to avoid too close contact of the facet joint, the surgeon accepts in some cases a lateral perforation, that is an intended perforation. Limitations, these are the limitations of the study. In spite of these limitations, this got it published. Pedicle screw scoring system is a method in which we can grade the accuracy of the pedicle screws. This is a standard guideline, but we have not been able to use this guideline. Bipodicals, pedicle screws is another thing which some people are recommending, but they are not clinically used because they carry the potential risk of damaging the prevertebral grid vessels. Ideally, the pedicle screw should be completely contained within the pedicle. But ultimately, patient symptomology is probably the most important factor in determining the acceptable positioning of the screw. Probably. Now to increase the accuracy, we have got a pediguard, we have got an OA, we have got a neuromonitoring, we have got a navigation. But I have included this X-ray, this CR image, which shows that while the screw was being placed, it dislodged medially. The surgeon who was putting in the screw took it out, changed, revised it. So at the end of the day, my conclusion is not. It is not. I am not advocating routine post-op CT. I am not advocating or saying that fluoroscopy guided conventional open method is anyway inferior. Because at the end of the day, we have got a probe in our hand in which we can probe the pedicle and check the accuracy. All of us surgeons would agree that an instrument becomes an extension of a surgeon's hand. And let us all be like Arjun, who was accurate in piercing the bird's eye during his Gurukul days, in piercing the fish's eye during his swimmer, and probably also the pedicle side. Thank you.
Thank you. Thank you very much, Dr. Raghav. Especially your time. Now we are going to have a very special session, HR Singh Manishan. If there is really a good question, you can come out with that. Otherwise, we should move to HRC oration. Thank you very much.
You have to go to all day for the oration. Thank you.
चेयर इधर से उधर दे दीजिएगा चाट चाहिए
Sir, start please. Welcome all. I welcome all of you on post-lunch session. चलेगा? लग जाएगा. We start with first speaker, wrong stem in revising failure of PHR.
दूसरा वाला भी है.
Dr. A.
पीछे भी है. नहीं नहीं ठीक चलेगा. हाँ हाँ चलेगा.
Sir, Prashad, he will speak on wrong stem in revising failure of PHR. Welcome, sir.
Thank you. Thank you, Dr. Lamba. I will be thankful to Dr. Amulya and his team for calling me to my birthplace, that's one, and giving me the opportunity to contribute on the topic which is close to my heart. Arthroplasty is the closest topic in orthopedics. So wrong stem, there are so many stems available, and depending upon what problem we are facing, we have to use them. It's a case-based discussion and we have to show failures, so I'll just combine a couple of cases and I'll try to show them. It's about a lady patient, 59 years old, that's 60. She had a fractured neck femur, was fixed by a multiple hip screw, ultimately failed, had an hernia, and that time I operated with a metal on metal. That is the ASR cup and a metal head with the stem device, and the stem had to have a sleeve so that the metal head could go into that trunnion. Anyway, she started having problems, the pain after 9 years of the metal hip replacement, and otherwise she is fit. And this is the exit. It started with infrequently and then became progressively limb and the pain. We can appreciate a lot of osteolytic areas. The first thing which comes to our mind is infection in our scenario. However, all the markers, excepting the CRP which was raised but not very profoundly, all other markers were normal. We were prepared to go for a spacer, but I was also prepared to do a revision. We took a aspiration, it came out blood only, no cytology was all okay, no malignancy. In fact, back of mind you also think of those things. When we opened up, we got a lot of this material, the blackish looking material. Is it metallosis? This is what metal on metal has got a specific reaction which is known as alveol, and this is what we had to clean out. I used a cup and a stem. Definitely the metaphysics was deficient, so I had to use the distal fixation stem, which is a fully porous core distal fixation solution stem. So here the bone grows inside the surface of the stem and has to be fixed distal. Ultimately healed well, but it took time. And if you look at the trochanter, that was tied down not by steel wire but fiber wire, because now fiber wires have come and I always use them now. They are not visible but they work very well. Another case similar. Here also the fracture happened while the surgeon was taking out the DHS. And he was planning it totally in fact. It's unfortunate that he broke a femur. I called the surgeon, I asked him what happened. He said it had too much of osteoporosis. Anyway, I went and I did a fixation, sorry. Can you go back? Anyway, I again did a solution, same step, the distal fixation. And I can also use the Wagner. In the similar situation, solution is not the only step. We have got a Wagner which is a little different, but it also works in the same principles of distal fixation steps. So these long steps can work very well to give a primary stability. Another one, infected case operated by one of my colleagues, did a spacer, ultimately asked me, in fact, he asked me to operate, and this lady, I was a little shaky, where I was put up a distal fixation stem. I used a reef stem which has got a distal fixation device. I really like this stem, I have done many now, but the problem is the proximal diameter is very huge and it's very difficult to fit up in normal Indian femur. But it works very well. Start our patient with partial weight bearing walking next day, and I can use it with a cemented cup or uncemented cup as the need may be, depending upon the age and what is the condition of the cup. So the stem is important, and then again it shows a good healing. Another one, a periprosthetic fracture in a cemented stem, and it was old case. Started on teriparatide, and I did a revision stem, but again a cemented stem. And I'm emphasizing on cemented stem because if there are multiple fractures, the cement is supposed to seep out. But if you try and compress the fracture before you put up the stem and ensure that it is fixed very well, the cables are tightened very well, it can work. And this is what here also I did a cemented stem. I'm not very sure which uncemented will go. The water I could have used, but this gave me this stability enough so that the lady could walk next day. And this is how the healing is after 6 months. And there is a paper which shows that yes, in old elderly people, the outcome of cemented femoral revision for periprosthetic femoral fractures is better or somewhat better than the uncemented ones. Whatever you do, don't do this. And this actually is not from India. This is from Switzerland. So friends, this can happen in Switzerland also. Thank you.
I was born Mrs. Mohanty from Bombay. We speak on gap balancing versus measured resection in total knee arthroplasty. Dr. S.S. Mohanty, sir.
With a good alignment and proper stability. That is what you aim at restoring in a total knee arthroplasty. So after taking a proper perpendicular tibial cord, with respect to the anatomical and mechanical axis, what you need to have a proper femoral component rotation in order to achieve a good rectangular flexion and extension gap. And in order to achieve a good femoral component rotation, there are two techniques which has been described. One is a gap balancing and one is a measured resection technique. The gap balancing technique basically it depends on the precise soft tissue balancing, whereas measured resection technique depends on accurate bone resections. So essentially the gap balancing technique where you do a ligament release prior to the bone cuts. So you correct the deformities, fixed deformities, and bring the limb into correct approximate alignment before determination of the femoral component rotation. So you release the soft tissues, give it to a rectangular gap, then you do the bone cuts. So whether you are going to flexion gap first or extension gap, that is the choice where varies from surgeon to surgeon. So in flexion gap, what happens? First you balance the flexion gap. You put the tension on everything. Balance the soft tissues, and after you have decided that it's an equal flexion gap on both the sides, then you take the AP cards, and then you make the knee in extension. Then you again you tension the extension gap, and after deciding the extension gap, take the distal femoral cut. So that balances, that is gap balancing technique. So the whole purpose of this thing that you have to take a proper tibial cut first and build the platform. So your tibial cut should be perpendicular to the mechanical and anatomical axis on the coronal plane, and has to be proper, in the sagittal plane to some degree of posterior slope you have to keep. So if you are taking a varus tibial cut, you tend to rotate the femoral component in internal rotation, and if you are taking valgus tibial cut, then you tend to take femoral component into external rotation. So while checking the flexion gap, you put the jigs there, then measure on both the sides, or you can use this kind of spacious blocks which are available in the manufacturer. Then you take the AP cut. After taking the AP cut, then extend the knee, again you tension the knee and check the extension gap and take the distal femoral cut. When you do extension gap first, then what you do, you take the tibial cut and distal femoral cut, then put this spacer block or one of the tensioner or lamina spreaders like this or spacer block, and then you take the AP cuts. So this is supposed to be more precise and reproducible by taking the extension gap first. So how do you tension? You can take one of these pressure blocks, take tensioners like this, lamina spreaders, or put the lamina spreaders and measure with a scale on both the sides so that it is equal on both the sides. The advantage of the gap balancing is that you have precise soft tissue balance without need for significant further release. So there is consistency in equalization of the extension and flexion gap, and it has been shown in the literature that the reduced femoral condyle lift ups when you are following the gap balancing technique in 30 degree, 60 degree or 90 degree of flexion of the knee, and it just gives a better coronal stability. But the pitfalls is that you need to have accurate tibial resection which is perpendicular to the tibia axis of the tibia. Your collateral ligaments integrity and function should be maintained on the medial side, the medial superficial collateral ligament, on the lateral side, lateral collateral ligament, and popliteus tendon complex. You remove the osteophytes early in your exposure during the surgery. Take out the tibial and femoral osteophytes. That is crucial because otherwise you tend to do more of soft tissue leading to instability. And of course there is a possibility of joint line changes in gap balancing technique. Whereas in major resection technique, the bone cuts are initially made independent soft tissue resection. So it depends the bony landmark like transepicondylar axis, the AP axis, as well as posterocondylar axis. The problem here is if there is a valgus knee with a hypoplastic, lateral femoral condyle, you cannot take it as a landmark, the posterocondylar axis, and whenever there is a ACL is absent or there is a intercondylar osteophytes like this, in those cases, you cannot rotate the anteroposterior axis in order to rotate your femoral component in proper rotation. So what is the best? What do I do? So it's a mix of both the philosophies, recheck one with the other. So go back a step, again the moment if there is an outlier, then correct it, and then correct that and go into the next step. So each case is different, like a valgus knee, intercondylar osteophytes, so customize your technique depending upon the situation. So in primary total knee arthroplasty, examine the patient on anesthesia whether it is a correctable deformity or it is fixed deformity. So after you assess it, then in the early part during exposure, take out all your osteophytes from the femoral and tibial side. Take the tibial cut first and take the distal femoral cut and check the extension gap. At this point of time, you check the alignment and stability and correct little soft tissues, whatever release you can do. Next, you do the flexion gap, and after doing so take out the osteophytes, and next proximal tibial cut and distal femoral cut, and you take and check the extension gap. And at this point of time, while checking the extension gap, you can see the alignment and the stability on each side. Next, you do the flexion AP cuts of the femur, taking the inter-epicondyle axis into consideration, and you can check again repeatedly along with the spacer blocks also whether your flexion gap is balanced, and take the anteroposterior cuts. So after taking the AP cuts and distal cuts, next you put the trial prosthesis and see if there is any tightness. You can do a pie crusting of the medial collateral ligament. And next you put the trial prosthesis in, check for the stability, and finally after cementing again you can check the stability as well. in this position. Whereas things are little different on the revision total knee replacement. When there, because of bone loss distal part of the femur, we check the flexion gap first, check the flexion gap stability. Next, see the interepicondylar axis and take the epicuts. And after taking the epicuts in the flexion, you see whether the joint line is restored or not. And finally, you make the knee an extension and check the extension gap. That is how you go in a revision situation. So this is a patient, 72 years old, recurvatum knee, valgus recurvatum knee. This is 8 years follow-up. So if you are doing your soft tissue releases and your bone cuts accurately, then even with a primary knee like this, you can achieve a good result even at 8 years follow-up of this patient. The valgus got corrected, the recurvatum got corrected, and there is a balanced knee and restoration of the function for the patient. So dear friends, take home message, there is a mix of both the philosophies, both gap balancing and major resection to be followed. Recheck one with the other, check at each step, after the bone cuts, during the trial reduction, and after cementing as well. Keep the constant implant always standby. In case you are doing over release, then you can use this kind of constant implants, and each case is different and you customize your technique. Thank you for a patient hearing, and I appeal you for my candidature for the post of Vice President of IOA this year, and request your blessings and support and help during the IOA election. Thank you very much.
Thank you, sir. Next, I would like to call upon Dr. Nishikant Kumar. He will be talking upon periprosthetic fractures around the total arthroplasty, the surgeon's disease.
Thanks a lot for inviting me. So I'll be talking about periprosthetic fractures around total arthroplasty. So it's definitely a surgeon's disease, because we create the problem for another surgeon dealing with. So the amount of numbers that total arthroplasty increasing is going to be the next epidemic. So it can be around the distal femur, around the patella, and the tibia. I shall be talking about periprosthetic fractures above the total arthroplasty and the distal femur. Causes can be trauma, metaphyseal osteopenia, the ankle notching. There is actually very high stress zone between the distal femur and the metaphyseal region. So that leads to these periprosthetic fractures. So who should be handling these problems? The arthroplastic surgeons or trauma surgeons? I think anyone who is able to handle both should be dealing with these kind of fractures. So classification: rhodoback and displaced, type 2 displaced with velvet prosthesis, and type 3 displaced with loose prosthesis. Type 1 can be treated conservatively, like in this case. Type 2 is the most common fractures. It can be treated by either nail or plate. In cases of poor quality of bone, we may need structural support like allograft. So to solve this dilemma, a new classification system has been proposed by Sue et al. So these classification systems only work if the problem is decayed and they dictate the fixations. Type 1 fractures is around the metaphyseal, diaphyseal regions. Type 2 start at the level of the anterior notch, and type 3 below the level of the prosthesis. So, like in these fractures, if this is a fracture pattern, you can easily do the nailing in these cases. And these fractures you can either nail or plate. While these are the ideal for lock plates. If the fracture line is below the level of prosthesis, this is ideal for the revision arthroplasty situation. So regarding nailing, you can only nail if the component has open box and the diameter of the box is around 12 millimeter. So this is a very interesting paper published by Haddockevich. So what they have done, they have drawn a line along the anterior cortex of the femur, and the measure the distance from this line to the prominence line where your interior part of the nail is, and divided this line with the widest diameter of the femoral condyle. This is called the starting point ratio, and compare this ratio with the femoral component ratios with the 1 millimeter plug. So you can clearly see there is a disparity between both of them. So this is the starting point ratio of the male, this is the starting point ratio of the female, and the femoral condyle ratio of the CRD and the PSD. There are mild difference between all these parameters. But if you look at carefully, between SPR of the female and femoral condyle ratio of the CRD, That's the problem. Because this difference is around 6 millimeter. This can push your nail posteriorly and can lead to decurvature deformities. So several authors have agreed that there are many component designs that can be nailed but can lead to this kind of decurvature deformities. Mostly in components that had a high FCR ratio. So this can be solved by using new nails called RF&A bicentennial, which have 10 degree of merger spread into it. So another problem. This is clearly two type 2 fractures. So this is ideal for nailing. The entry point is center in both AP and lateral views. But if you look at carefully after putting the nail is abutting the lateral cortex. So you have fixed a nail very low and very high. So this can create a windshield wiper effect. So this can lead to the various deformities. So how to prevent it? Just add polar screw into it. This will effectively narrow the metallic canal diameter. So your nail can't shift, but if fracture is stabilized. So this has solved most of the problems with nailing. So this is the final construct. So under Phillips element analysis, we just compare lock plate with nailing and lock plate with nail. The strongest construct is lock plate with nail. Like in this situation, the fracture line is there but extending up to the anterior cortex. So what I have done, used nail with plate construct. Another case, although thick above, this is complete kind of fractures. Use this duplicate nail and plate construct. So lock plates are ideal in two type 2 fractures. Like in this scenario, you can see the fracture is at the level of the anterior cortex of the prosthesis. So use this dual plate. This is a Phillips plate put in medially. This is the 6-month follow-up. So in most of the cases, you don't require the bone graft. You can add a plate to it. Like in this case, this is a fracture, so type 1 fractures. Plate has been done, but it broke. Came to me with this kind of situation. Revise it, revise in this plate. So added another plate. This is a variable length plate with a dual plate construct. This is the 1-year follow-up. So type 3, if there is no metaphyseal bone loss, go on to revising it with a long stem prosthesis. If there is a metaphyseal bone loss, the distal femur replacement is a choice. So this is the case of bilateral arthroplasty done by me. 2 weeks post-op, patient developed bilateral periprosthetic fracture. In right side, it was a stable kind of construct was there, the prosthesis was stable, and the left side, the prosthesis was loose. So on right side, you want to just fixing it, while the left side, revised it with a hinge. Another case of this 80 years old female, severe OA bilaterally, did this knee in the right side, 2 week post-op, got this fracture. There was a huge metaphyseal bone loss was there. So go on to revising with a distal femur replacement in this case. So this distal femur replacement is ideal in situations where your revision fixation is likely to fail, mostly because of mechanical factors, the implant loosening or the patient-related factors. So my conclusion would be, the important thing to dictate the decision making in these kind of periprosthetic fractures would be amount of remaining bone stock remaining, how is the bone quality, the fracture morphology is important, and the degree of cognition and the patient activity level. These all things has to be kept in mind before dealing with these kind of fractures. So thanks a lot for your patient hearing.
Dr. Vidya,
Can I ask one question here? After
And in India, we are performing around 3 lakhs of TTR. With 6 crores of active osteoarthritic cases in India, we are on a path to become the osteoarthritic capital of the world. So, are the patients satisfied with this TTR? We are, there is merely 300 of TTR that performed in 1994. That jumped to 1,75,000 in 2017. And last year we have performed 3 lakhs of TTR. So are the patients with TTR performed satisfied with this? This literature was published in this month in Journal of Arthroplasty that clearly says around 10% of patients are dissatisfied with this. So what is the common cause of dissatisfaction? That is, we are all talking about this anterior knee pain. Other causes may be implant loosening, there may be infection. So what is the cause of anterior knee pain? Basically, when we see the articular cartilage is illegal, but the substance around the patella is basically rich in substance P fibers, that is nociceptive receptors. So laterally it is supplied by lateral femoral cutaneous nerve of thigh, anteriorly anterior cutaneous branch of femoral nerve, and medially by medial femoral cutaneous nerve of thigh. So why patellar denervation should be done? Very easy implementation. Basically, we have to just innervate 1 to 2 mm of depth by electroporation, and no other additional surgical procedures have to be performed. But the disadvantages are, it is potentially harmful to the articular cartilage. So we have to be careful regarding that. Anterior knee pain may occur, and there is published literature regarding that there is need of secondary resurfacing in 10 to 12% of cases. So we are talking about if resurfacing. So what are the disadvantages of resurfacing? Patellar fracture. In an unpublished literature of myoclinic by Mary et al., in 24,000 of cases, primary TKR, 4 cases of patellar fracture was occurred. Another disadvantage is osteonecrosis that may happen. Aseptic loosening of the implant, that is another cause. If the implant is not of proper size, then overstuffing of the patellofemoral joint may occur. Polythene wear, and there is learning curve, that is deep. So what about patellar denervation? Another paper by Spencer et al., we are going 1 month back. This literature was published regarding patellar denervation with circumferential electropoietry. But this, the conclusion of this literature is it is not recommended for clinical practice, as it does not improve the anterior knee pain. So going back 2 months back, 2 years back, this literature was published by Corey et al. This is basically National Joint Registry of Australia that included around 6 lakhs of TKR, and in which both type of TKR were performed, PS knee, CR knee, resurfaced and all that. And the clear indication was that, conclusion was that resurfacing of the patella reduces the rate of revision, and there was no extra benefit. So another literature that it was published by Arte et al. 10 years back, in which bilateral simultaneous TKR was performed, in which one patella was resurfaced and other was denervated, and he clearly concluded that it has reduced anterior knee pain. So to conclude, if the TKR is going to be performed for patellofemoral osteoarthritis, then we have to resurface. Otherwise, there is no harm in denervating the patella. Here are few cases that was done by not resurfacing. Here is the clear case. You can see here the other limb is amputated 10 years back, and he is walking comfortably after completion. Next one is 54-year-old female having bilateral severe osteoarthritis, and she is walking comfortably. In this particular case, 62-year-old male having, you can see the gait of the patient, and after operation walking comfortably, but he had slight anterior knee pain. Another case was walking comfortably. Here is the post-op X-ray and review. This patient was unable to walk for few steps, but after operation he was able to walk and go to bathroom. Thank you. Thanks.
I call Dr. Deep Geza. He will speak on why I prefer PS design here.
Good afternoon. Thank you, sir, Dr. Lamba, sir, and thank you, Dr. Amulya and GOFCON organizing team for inviting me here. I'll be speaking on a very simple topic. My talk is why I prefer PS design over CR knees. I am working in Gangaram Hospital for last almost 25 years, and the two main goals of TKR are to obtain a stable knee with functional improvement and to correct deformities. There has been much debate about which design is better for achieving these goals between CR and the posterior stabilized total knee arthroplasty. Each type of processes has its own advantage and disadvantages, and most studies have failed to prove which type is superior to the other in terms of functional outcome range of motion, kinematics, and long-term survival rate. This is PS knee. If you see here, this is a post, tibial post, and with a cam in the femoral component, which articulates in such a way to work like a PCL for femoral rollback. And this design was developed in 1978 by Insal and Bustin, and still maintaining with a few changes, but the basis is almost same. The PCL function is taken over by this tibial post and the cam for the femoral rollback. If you see the design of the CR, this look like this, the pegs only, but in the PS knee, this is the tibial post with a cam in it, so that it can work as a perfectly femoral rollback. This is how it works in the extension as well as flexion. What is the advantage of PS design? Easier ligament balancing, conforming articulation, better knee flexion, more predictable kinematics and reproducible rollback, lower range of axial rotation and condylar translation, avoiding risk of progressive PCL insufficiency. These are very important, and the young surgeons who are beginning their arthroplasty, they can go for PS knees. Indication: severe deformities more than 20 degrees in our area, like our patient comes very late, around 60 plus, inflammatory arthritis, post-pedlectomy, altered geometry of femur or tibia, in the case of previous STO, or sometimes old Chiru-Valgam cases, in the cases where the PCL is deficient knees, we are planned only for the PS knee. The severity of deformity should be considered before surgery. Presence of significant coronal and sagittal malalignment and possibility of difficulty in balancing often necessitate section of the PCL. PS total knee arthroplasty is a preferred procedure in the presence of fixed flexion contracture, especially in the knee with a fixed flexion contracture of more than 20 degrees, because a symmetric flexion and extension gap is easy to obtain when the PCL is dissected. The rate of conversion to PS total knee arthroplasty in the knee, the flexion contracture more than 20 degrees was nearly twice higher than that in the knee with the flexion contracture less than 5 degrees. Contraindication for CR TKA includes PCL insufficiency, posterior lateral instability, significant coronal deformity, inflammatory arthritis, and extensor mechanism deficiency. We should always know about the past history of operation. The history of previous operation includes internal fixation of fracture of the knee, STO, or unicompartmental knee arthroplasty which are failed, indicates the poor quality of the remaining ligaments. The posterior lateral corner injury would inflict greater strain on the remaining PCL. Therefore, in patients with a past history of trauma or surgery around the knee, accurate soft tissue balancing would be easier with PS total knee arthroplasty. Even the intra-op, sometimes you have to understand the status of PCL should be evaluated carefully. The finding of PCL insufficiency and poor elasticity of the degenerated PCL constitutes a contraindication for CA total knee arthroplasty. Bone defects or the need for augments are factors that do not favor for CR total knee arthroplasty as well. Patients with this condition will not be proper candidate for CR TK because most manufacturers do not provide a metal augment or stem for CR total knee arthroplasty. The conversion rate from CR total knee to PS was high in patients with severe flexion contracture, steep posterior slope, and small femoral component. We think those factors should also be carefully considered for appropriate selection of the prosthesis type. In the first generation of PS femoral component, we have got this syndrome called patellar clunge syndrome, was known to increase the risk of post-operative patellar femoral clunge or capitus, and it is called as PCS, patellar clunge syndrome. It occasionally occurs after PS knee and is characterized by painful, palpable, audible clunk of the patella when the knee moves from flexion to extension. It has been classically attributed to the formation of fibrous nodule at the junction of proximal pole of the patella and the undersurface of the distal quadriceps tendon. This is how it looks. If the petal is resurfaced, there is a nodule formation in the proximal as well as distal cone of the patella, and which creates a noise in the knee joint. And in one case, we remove this fibrous tissue, both the ends, and the patients do well after the surgery. It mainly occurs on those knees where patella is resurfaced and not rarely in the non-surface of the patella. Contraindication of PS knees: when one or both of the collateral ligaments are significantly lax or disrupted, then you can't plan for PS knee. Failure to obtain balance, extension and flexion gap after PCL resection necessitate conversion to varus and valgus constraint implant. The take-home message is the surgeon should have a clear idea on the technical difference between CR and the PS arthroplasty, the extent of distal femoral infection, selection of femoral component size, adjustment of tibial slopes are vertical crucial for successful TKA. There was no difference in clinical result, range of motion, kinematics, and survival rate between CR and PS in most studies. Therefore, adherence to surgical indication and understanding of those differences in surgical principles might be more important than the selection of the process style. Thank you.
Thank you, Dr. Pradeep. We'll take the question at the end of the next lecture. Now, I would like to call upon Dr. Pradeep. He'll be speaking on TKR and medial bone loss, which is a very common scenario in our patients.
Good afternoon, everyone. Post-lunch session on this difficult. So it's nothing. It's nothing uncommon that I'm going to present, because this is a very common scenario. Everybody sees varus knees. Most of the knee are varus, and most of them have a defect on the medial side. So we'll see how I manage, and probably everybody over manage. We'll just show you how we manage it. So we know that strategies in managing totally is that intra-articular and extra-articular, both the deformities has to be balanced. It's bone loss and it's intrinsic or extrinsic secondary to erosion, and it's mostly on the tibial side. The idea is to do a good soft tissue release. So it's MCL, capsule, press sensitive tendon, PCL, osteophytes. I'm a completely PSV surgeon, so I cannot give you any input on CRT. So completely two declaration, PS and never replaced a patella. Okay. So 1,000 knees never replaced a patella. But good or bad, I don't know. That's a different question. So the idea of releasing all the soft tissue is that release all the osteophytes. And go posterior. So it's always being told you will start anteriorly and go medially. Basically, you have to posterior medial is the one where you have to release, and you have to be very careful. You have to assess, release, and then assess. You cannot go in all out releasing completely and you think that you have done a good job, or you may land up in trouble. Definitely. Patient like this comes very often to all of us in India, and you want a patient like this at the end of the day. And I hope the video works. Yes. So the idea is to release all the osteophytes, everywhere the osteophytes have to be removed, because these are the osteophytes which are stretching your ligaments, and they may give you a false impression other than the defect. Okay, and you may end up in having this much of bone at the end of the day after the cuts as well. So idea is to remove all the osteophytes, all the broken pieces of the bone. The problem is this contrast is a bit too much here, but what you see here is that after the cut, and when the PVI is being taken, I think PVI has been made, we realize that okay, there's a big chunk of bone in the back which was there and we didn't realize. Now what will happen is that you have taken the cut and you have made the TVI and everything. Now the moment you release this, it will open up drastically. So you have to be very, very careful before committing to the cuts and everything. You have to remove all the bones and broken pieces. Okay? So you have to remove. So here we are removing it. Through contrast now. So we are removing all the broken pieces here, and then we'll go with making the tibia. And it is in this video just showing that you have to remove all the osteophytes, all the capsular release. Posteriorly, you go posterior and release all the osteophytes, release all the capsules, everything posteriorly, medially, and then you decide upon the size that you are going to take, release, assess, and then manage your defect. Again, the same situation, you have to take out all the osteophytes, all the bone cuts, everything that you have done. And once you have done with it, you will find that releasing the ligaments and the soft tissue. Of course, you will end up with a defect like this, which is just coming up here. Okay, you will end up with a defect like this because it's a defect that patient already had when he came to you. It's not what you have created. And these are the defects that you have to manage. Okay, so how do you manage the defect in next 3-4 minutes? So these are the defects. So you can manage it in a different way. So you can manage it with a wedge. You can manage it with a augment or a wedge, we call it. But then you need to understand that the wedge, at least it should be 5 to 10 mm defect has to be there, and there has to be a floor over which the wedge will sit. If you don't have the floor, the wedge, it will fail completely. So you need to have a floor where the base of the wedge will sit. So that is number one. That is the most important. Okay. In this slide, what I want to tell you is that getting a CT scan is very helpful many a times, because you know where exactly the defect is, how much the defect is. Do you really going to get the floor of your defect or not to put in a wedge? That is how you're going to manage the defect. Okay, mostly you don't get a floor, and you when you get a patient like this, and you have to start thinking and you have to start planning before you end up in the theatre. Okay, and the defect like this, you end up with a defect like 2.5 centimeter on the posterior medial aspect, defect like this, and you can manage it with the screws. We have burned our fingers when we have just put in the screws without bypassing it. If the defect is small, 0.5, half a centimeter, you can put in screws built up with bone cement. But remember, whenever you're putting the screw, do bridge it with a intramedullary rod. That is very, very important. Otherwise, you'll end up in trouble in longer run. A patient like this, you can see the CT scan. It's a huge defect. You have to augment. You have a lot of bone at the end of the day when you have taken your femoral and tibial cuts. So in this defect like this, you can use those bones. Of course, you have to freshen the surface, that is where you are putting the bone, because when you see a 3-month X-ray, you will find that your bone, it's completely gone. It disappears, though it appears over a period of time, but it may just disappear. So these are the defects that how we manage it. We put up the bone, put screws. We bypass the screws with where your rod is going to be, and of course you cement it. Some of the X-rays, bone again, and you have distal femoral cuts, proximal cuts, and you have to bypass it with a rod. All the defects where you manage, you have to bypass it with a rod. Just another example how you do it. Of course, when a patient like this comes, you have to think in a completely different way. You have to, patient like this will come to you, and then you are left with no bone, so you have to think about bone metaphyseal sleeve or bone construct, which gives you a very good fixation and a long-lasting result in these patients. This is just some slides showing that. So probably my take-home message would be decision-making radiology is very, very important. And as before you go into the theatre, plan everything in advance, plan with proper implant. Coverage and support of the tibial tray is of paramount importance. No matter how good the surgery is, if the coverage is not there, it's not a 1-day or a 15-day surgery that you go and patient will forget. Patient will keep coming back to you for next 10 to 15 years. Remember that. You have to give a result for next 20 years. So that is, nobody is going to take your failures. Thank you very much.
Thank you. Now we have a small session. Question and answer session. Anybody have any questions?
Yeah, I think I do also have a question for Vidya still here.
You have 5 minutes for question.
Yeah, so do you recommend denervation or not? What is the recommendation? Denervating patella, how many of surgeons, how many, just a raise of hand, how many of us do that? How many of us replace the patella? In every case, sir does, I know. Sir does, and 1, 2, Bharti sir, okay. And, okay, but he has it, sir. So routinely, sir, you replace it routinely if I'm not wrong. And you also replace, every case you replace it routinely. Okay, your reasons for replacing it routinely, can you just briefly repeat?
Because I understand that the patients, they only need to walk, they need to go up and down the stairs also. And all those patients where the patella was not really surfaced, either by me or by other surgeons, they definitely had difficulty going up and down the stairs. Number one. Number two, once you are doing a job, if there is a patella, it doesn't take more than 5 minutes extra.
Time-wise, it is not nothing. Time and money, it's not a constraint.
Exactly. So that's the reason why I usually leave.
I just want to know the thought process. Why you replace every patella?
Just trying to minimize unhappy patients.
Unhappy patient. And do you have any specific size before over which you will, under which you will not at all replace it?
Yes, I mean, yes, if the patient is underweight, number one. Number two, recently I did one where the patella height was only 19 mm. So these are the cases where I definitely.
Sir, Mohanty sir, so your 2 reasons for replacing all the patellas and where you will not consider replacing.
I go in Dr. Anava's principle that how
Yeah.
a cartilage will rub against a metallic part and it will not hurt. I have seen more of complications of not resurfacing patella rather than complications of replaced patella. Many patients who are patella is not resurfaced, they typically complain of 2 things. Getting up from a chair, they get pain. While climbing down the stairs, they get pain. That is and they are unhappy patients. But if you are not replacing, then denervation, of course, should be done. And while doing denervation, one should be very careful not to, injure the suprapatellar branch of the retinacular artery. If you take out that, then there is a possibility of vascular.
In my short practice, I have not got any complaints and never resurfaced patella. This is my experience. What was your message after your paper?
Just one comment I would like to make. So whether you resurface the patella or not, one thing is for sure, that if you have not resurfaced the patella, never revise it for anterior knee pain and put in a patella. That's for sure.
Sir, actually the paper says if the TKR is being performed, for petrofemoral osteoarthritis, that is the patella is the main reason, patellar osteoarthritis is the main reason, then you should go for resurfacing. Otherwise, patellar denervation is no harm. There is no harm.
Tri-compartmental OA we are talking. So in that, what is your message? Resurface? No, because you have done a lot of study.
Yeah. I have done studies. But in my conclusion, I have concluded that there is no harm in doing patellar denervation.
At the end of your paper, what is your clear-cut one message?
Patellar denervation is the basic.
You have to do a patellar denervation.
So
And what
question.
about replacement?
Sir, I have
Only one question.
No, sir. I have
I got one question for the concerned person. He has done 2 bilateral TKR and 2 weeks later you revised them, yes? What was the reason of periprosthetic fracture? How is it?
Periprosthetic fractures were
Injury or?
Yeah, the hyponatremia was the cause. Detected later on, so it fell off.
Both the patients?
Both the patients.
It was same patient with a bilateral same patient. इसमें दोनों knee fracture. Same patient. There was a patient, same patient.
Okay. Bilateral knee was done. Sequential bilateral knee was done. She was discharged on the 7th day of the post-op surgery. She went home. She fled on 2 weeks post-op.
For those cases,
he did such a good job. The patient was running up and about, and that's why they are up.
So it's injury basically.
Injury.
So for those cases like 80 plus patient, am I right?
Yes, plus 81 plus patient.
So the message is here. You should always have BMD. It's an important message because when you put the hammer, the femur component, she had a fall. Fracture we consider it a fall, but we never know. Your notching has done something there also, that hammering. Because 80 plus bilateral TKR, and if you feel something,
I think one thing which I will take relation from that case, 80 plus, I would have done a CRD, not a PS knee. So the incidence of pain positive fractures, what your topic was, that the CR versus PS, you should always perform the CRD because it then take out the box.
Please go for a small box. It's good now. Not the first.
Why not do the CRD?
But my message is, BMD should be done. Please.
Okay. Now we close the question and answer
What's the
session.
process?
Yes, we are running.
Minus 3.5.
You have to wait first, and then.
How long you can wait? You can't predict how
Ceasefire, sir.
for the BMD to
Sorry. We just move on to the next session. This can continue over a cup of
Why
tea
are you
also.
sitting in the same sitting?
You're talking.
No. He's saying that leave the BMD support security of the body. Will you reduce the surgery?
You defer it.
How long?
For a year.
Actually, sir, see, suppose 80 plus.
See, there are two school of thoughts that okay, you build up the
these
patient.
patients to be moving.
Yeah, without any fracture, and which can easily happen, which not going to happen unless and you replace it. So you have to find a
Dr.
medicine.
Sudhir, please.
Thank you. Question for you.
We are moving to the next session.
Next session.
Yes, sir.
And in between, the lucky draw has come with Dr. Dhananjay Gupta has picked up. Unfortunately, I will say it's going to our chairperson.
You should share it, you know.
You have worked hard. I will request Dr. Anup to present him. This trolley bag.
सर भाई हो गया आइए हवाले You speak on replacement build intertrochanteric fractures. Dr. Singh.
Chairpersons, my presentation is on replacement in failed intertrochanteric fixations. In spite of adequate fixation, implant cutout, desurgery is not possible due to the poor bone stock, due to the hollow left behind because of the continuous movement of the implant. Or we have a situation where the screw gouges the acetabulum, leading to a bony defect and erosion of the acetabular cartilage. Or in an elderly, there is a non-union, a painful malunion, which can be an indication for a total hip replacement. So decision whether to refix or to replace depends on the age. And in the elderly, we have two situations, whether to do a hemi or a total, and that depends on the physiological age, life expectancy, bone quality, condition of the hip joint cartilage, and the functional level of the patient. The technical hurdles while doing these surgeries is the surgical exposure is difficult because of the previous surgery and scar. Removal of the broken fixation devices, whether it is a hip screw or a cortical screw, or there could be altered anatomy because of the malunion or a non-union of the greater trochanter, or there could be a compromised bone quality due to the pre-existing osteopenia, disuse and immobility. There can as well be bone defects after extraction of the failed implant. There could be difficulty in orientation of the stent, and there also a high perioperative fracture risk because of the immobilization, prolonged immobilization. Coming to the first, the technical difficulty, it is the incision. The previous scar is anterior to the second, the posterior, which we take for replacement. Most of the time, all what you have to do is extend the same scar proximally and posteriorly, and if you externally rotate the hip, the lower limb, probably you will be able to take out the implant by the same incision. The TFL is adhered to the trochanter most of the time. Release the fibrous tissue so that the trochanter moves freely while rotating the limb, so that no tissue is adhered to the greater trochanter. Release the contracture anatomy so that we look at the lateral side the vastus lateralis is seen and the trochanter, and above that are your abductors. Hardware removal can be a nightmare, but when you have a hip screw like this, dislocate the hip first, otherwise you will end up in a pathological or a iatrogenic fracture at the level of hip screw. Probably they have moved from that to here. They continue to make noise. Can you request them? The other technical difficulty is the trochanter. It is usually widened because of the previous surgery. It may be a mass, it can be an abnormal position, and most often it doesn't allow the entry in the stem because the large mass of the trochanter overhangs and does not allow entry for the preparation of the femoral stem. There may be a lot of callus around or heterotrophic ossification, and in some situations there could be a non-union which we have to refix wire or cable, or we have to put a hook plate. The other technical difficulty is achieving a limb length. Sometimes the landmarks, the lesser trochanter or the greater trochanter, are not available in a bad situation. The greater trochanter and the calcar is separated from the shaft. So pre-operative templating and eyeballing, looking at the previous screw holes and intraoperative imaging when you are placing the stem are very useful in getting a right orientation. When you have a non-union of the greater trochanter, it is very easy approach after having removed the implant. Then just by releasing the trochanter, the fibrous tissue non-union, then you can approach the neck and the head directly, and then remove the head, and then go ahead with the stem preparation. The technical difficulties can be how do you plug the holes of the removed cortical screws, and second is we must bypass the stem by at least 2 cortical diameters when you are using a long, and then you have to use a long stem. The head acts, the extracted head can have a good graft which can be packed in the acetabulum, which can be used to build a calcar, which can be used in a non-union of the trochanter to get a good healing, or you can use that to plug the hip screw hole or a cortical screw hole. The calcar can be rebuilt by available extracted neck of the femoral head, and that can be used to rebuild the calcar, and then either use a cemented or uncemented stem. The calcar defects can be replaced by either choosing a calcar replacing prosthesis if you have a large defect, or you can use a SROM or other design of femoral stem. Trochanteric wiring, particularly when you have a non-union or a fibrous union, is always useful. You can also do tightening or lengthening of the greater trochanter to get a good abductor, and you can wire them in a fashion, and the graft can be used in between the shaft and the trochanter to get a good union. The complications related to this, particularly in the intertrochanteric, are the dislocation, which are to the tune of about 23%, but that reduces to almost half when you have doing a replacement for a neck femur. The instability is particularly seen when the calcar is too short, or you have not achieved appropriate length between the tip of the trochanter and the femoral head. So trochanteric stabilization is a key whenever you are considering a refixation. Whether to use a cemented or uncemented depends on the surgeon and the age of the individual. A long stem should be extended beyond To conclude, hemiarthroplasty, hemi may be a reasonable option in a low demand and a total hip in a most predictable in an elderly patient. It is a different surgery from a primary total hip in a fresh trochanteric fracture. It is as difficult as a revision surgery because there are no landmarks and the anatomy is distorted. Needs planning, proper implant selection, and a calcar replacing prosthesis is very useful. It is the effective salvage in the elderly for a failed intertrochanteric fracture. Will have 90% good to excellent result. Most patients have a good pain relief and a functional improvement. A calca replacement and a long stem implant often are required. The outcome, though very less, which are published, but they have an excellent outcome. Thank you very much.
Thank you, sir. Now, Dr. Sujit Tripathi. Friends, as you know, there is an emerging trend in total hip arthroplasty scapular fracture, primarily or secondary. Now, here Dr. Tripathi will say when and how.
A very good afternoon. Thank you, Dr. Amulya and organizing team for inviting me to this conference. It was really wonderful to have it here. Last one. Yeah. So there are three scenarios in acetabular fracture who comes to us. One is where the patient is previously been fixed and they develop some form of complication like arthritis, osteonecrosis, infection, failed fixation or some form of complication. Second one is neglected acetabular fracture, that means inadequately treated by the doctor or neglected by the patient himself if the patient that means neglected for a long period of time and end up with some form of complication like non-union, malunion. And most of the time it is a combination of non-union and malunion. And the recent trend is going on towards acute acetabular fractures where most of the elderly patients with severe conditions where the cartilage defect is more than 40% of the acetabular side, probably those conditions are coming for total hip arthroplasty. So in these three scenarios, if you see, the problem is different. When you manage it conservatively, there is a distorted anatomy is there. It is a non-union, sometimes it is a malunion, or a combination of non-union malunion leading to there is bone defect. And in a previously operated cases, there is prior hardware, infection risk is there, and abductor deficiency is one of the common problems. But in acute THA, it is a non-union or the fragments mobility. So the stability of the component is a bigger issue. So pre-operative evaluation we do all these radiographs, CT scan, ultrasonography, but definitely you should rule out infection and evaluate the abductor dysfunction here. And this is the protocol I follow, particularly cavitary defect, you need to fill up with infection, bone grafting and do a total hip arthroplasty. If it is a segmental defect, probably you fill up with some strut graft, then do THA. When there is a discontinuity, probably it is better to go for anti-protrusive cage, cup cage construct or destruction technique. And if there is no defect, probably you can simply go for a simple standard THA. But if hardware removal, the concern is that if it interferes with your positioning of your cup, then probably you need to remove that. So these are the problems after previously operated cases, but I will stress on two factors. One is infection, be sure that the infection is not there, and the last one is the abductor deficiency. Regarding cup stability, how to achieve cup stability, you should raise the cup between 2 points, that is the anteroinferior iliac spine and ischium. And if you cannot get stability, probably you need a bone graft and plate. So what is the ideal implant? Definitely uncemented one, highly porous cup, multi-pole dual mobility cup. And this is where you need to put the screws. So there are 5 corridors you should see. And see which corridor is articulating with the axial skeleton and put a screw in that segment if the other segment is involved. So these are some of the examples, we will go through that. 35-year male, that is a posterior wall fractures where it has been fixed with screws that developed ABN. There was no interference with our THR, so we just went up with standard THA in this case, and this is 3 years follow-up of these patients. This was another case, 27-year male, previous osteosynthesis for 3 months old neglected acetabular fractures. Now the question is where to put the cup. If you place it medially, what will happen? It will lead to impingement and dislocation. But if you place it lateral, so look for the stable joint which is articulating with the axial skeleton, and it leads to better cup stability and biomechanics. And so lateralizing highly porous cup and augmentation of the wall if needed. So this is that 2 years follow of this patient. Now the problem is a 26-year female bone defect. Here the problem is the hip joint has gone upward. It has been operated 3 times outside. The abductor has been detached and the detachment from your retrotrochanter. So in such conditions, you should look for the CT scan where the hardwares are there. So you need to remove those hardware, and I accepted a high center in that particular case. This is another patient where, This is another patient where multiple screws were operated and extended iliac femoral approach was used. So abductor was gross detection in this patient. So, and this patient was having diabetes mellitus with autonomic dysfunction. So blood pressure was immediately dropping to 60 like that in the systolic blood pressure. And sometimes it was raising up to 120, 130 like that. So I decided to operate it in stage-wise manner. The first stage I removed the plate, and the second stage when I evaluated with dual mobility cup also it was dislocating, so I just planned for a constant liner in this patient. And this is 7-year follow-up after this patient, and this patient is still doing well. And the sciatic nerve, which was damaged initially, has improved significantly. Another case, how to deal with intra-articular hardware. So here there was a prominence of the screw. So you have three options: either you can remove it, but it needs another approach for that. You can use a metal cutter, or you can bury it and do minimal lateral action for that. So this is what we did. We just put the bone graft and lateralized it. Lysis, so you need to do a graft like this. When you deal with protrusio, you need to do autograft. Put the autograft there and lateralize the cup. When it is not interfering, probably you can go for a standard THR. Now in a neglected case or conservatively treated case, you cannot negotiate the column completely. So near anatomical reduction is needed. And then you put a plate, fill up the defect with bone graft, and then you go for a highly porous cup. So the same protocol that I follow. Here again, a bicompartmentalization of the sternum was there. So I just ringed it, put bone graft on the medial side, and put this cup there, standard cup. Here under the 64-year male, 3 months old posterior wall fractures. So this is what I do. I put a bone graft on the posterior wall, then buttressed it with a plate, and went for a highly porous cup. This was another patient, 4 months old, 64-year-old, again the same construct. 9-month-old, again the same construct. But the principle is that I never start reaming without fixing a buttress plate on the posterior side. So that is what I wanted to say by saying that why fixation of the neglected posterior wall fractures. So this is at 1 year follow-up, and now this patient is doing well. This is again neglected sternal fracture, 6 months old, primary osteosynthesis was done and along with simultaneous THR. This was a central anterior column defect, bone graft was put, and this cage construct was done. Pelvic discontinuity, when it is acute, you can go for a highly porous cup in such conditions. If it is a chronic one, probably it is better to go for anti-procedural cup cage. So acute sternal fractures in patients of elderly patients when there is gross comminution, there probably it is better to go for a direct fixations and putting a highly porous cup. This is one patient where I failed. Basically, there was grossly counted posterior wall fractures. I couldn't do anything, so I took a graft, iliac crest graft. It failed later on. During COVID time, I operated this patient, and this is at 9 months follow-up. He came to me with fusion of that particular head in the ilium. So this is what we did while just dislocating its probe. So this is another question. If it is a small fragment, probably you can ignore that and remedially. And this is how you can do a total arthroplasty. This is another patient. Acute fractures, I went on the anterior side, fixed with the plate, then went to the posterior side and fixed with the plate and did a standard THR. Yeah, just so these are anti-proteasal cup cage. And if you see the little, this is pathological sternal fractures. Chondrosarcoma was there, so this is what I excised it, and this is out of the way, I would say, because I took the bone graft, fixed it, and put a rim plate there and gave the THR, but the patient died of COVID after 2 months. So this is a take-home message. THR after sternal fracture is challenging, but you can, the key to success is stable fixation, stable socket, and stable hip. And recently the highly porous multi-hole cup, dual mobility cup, and TM augment and buttress have solved most of these problems. So thank you for your attention. Thank you.
Is going to speak on total restricting weight fixation. Dr. Restricts.
Good afternoon, colleague. Our topics are quite similar, so most of the topics will be covered by the previous speaker and Dr. Research. I'm starting. I still the preferred treatment for proximal femoral fracture is osteosynthesis. This treatment is gold standard. But the incidence of non-union and plant failure is 3 to 8% for IT fractures and 10 to 25% for the fracture neck of femur, as mentioned in different literatures. Most common cause of fixation failure is inadequate
inaccurate reduction, inadequate fixation, vascular damage, and infection. And the most common indication for which we do the THR is the screw cutout and avian. Another cause was the infection and osteoporosis, not so common. Not going to the stage, most of the things covered by the previous speakers. Few points I like to highlight, especially in vestibular preparation. Vestibular bone quality is not good in cases of IT fractures. So reaming the vestibular cartilage should be done very judiciously. Try to preserve the subchondral bone. Adequate press fit may not be achieved. So sometimes you need to augment the cup with multiple screws, or you may consider placing the cemented cup rather than doing over reaming. And forceful vestibular component infection should not be tried. That can lead to the fracture. Femoral canal preparation is difficult. Fracture callus, non-united fracture translation, and malleolin often result in bone deformity of the proximal femur. And most difficult one is the industrial sclerotic bone around the track of the previous intermedullary vein, and the lag screw. Need to remove it very cautiously. If we don't remove it properly, our remus or canal openers tends to go laterally and tend to perforate the femur. There is high chances of fracture and displacement of the skin, both during the insertion and also during the canal preparation. Primary implant is usually sufficient. You can choose cemented or uncemented as per your choice. Displaced trochanteric fragments need to be repositioned just to avoid the high dislocation rate. The method could be the tension band wiring, trochanteric lock plating with the wiring. The key is to pass the wire before implantation and tighten the wire after reduction. The advantage is reduction of displaced trochanter and the chances of union is there, and complete soft tissue envelope that leads to less chances of dislocation post surgery. Coming to the case, this is 48-year-old male, fractured neck femur in December 2016, treated with DHS and relocation screw. Presented with painful limp to us in November 2017. Initial X-ray, fracture neck was there. It was treated with DHS and relocation screw. Non-union and avian, which is treated with the DHS. This is 1 year follow-up. Patient is going well. Here's to similar case of 55-year-old male, fracture neck of femur in November 2015. Treated with CC screws, multiple CC screws, presented with limp February 2016. Initial X-rays, fracture neck femur, capital type, high chances of failure. Fixed with the screws, non-union and some avian, treated with the EHR. This is 1 year follow-up. Case 376-year-old male presented with discharge of pus and limb in February 2022. History of IT femur fracture fixed with PHS 2 years back. This is the X-ray when patient present to us. The surgery was done in 2 stages. First stage we removed all the implants, back with the infection, back with the antibiotic cements. Waited for the 2 months. When the DHR is done, this is 1 year follow-up X-ray. Fracture is almost united. Another case, 57-year-old male, presented with painful limp in August 2019. There was history of fracture neck of femur 1 year back. Leads to avian, DHR done. This is a follow-up X-rays after 3 months. Patient is doing well. So coming to the complication, in these cases, these surgeries are much more complicated than the primary one. Intra fracture is common through the screw holes, and GT avulsion, chances of GT avulsion is high if you don't release the tissues properly. There is high chances of bleeding more than you expect, so always arrest the blood. Chances of infection is more, and chances of dislocation is also more. The most common cause for dislocation, especially in cases of IT fractures, is the incorrect moral component and reversal. But coming to the conclusion, should we do or not? So this is the highly successful surgery, significant reduction in joint pain and early range of motion. Thank you.
Now I call Mr. Rajiv Anand. He will speak on
Thank you, Chairperson. So today I will be talking about THR in ankylosing spondylitis or ankylosed hip. So it mainly affects the sacroiliac joint, spine, hip, and very less commonly the knee joint, with a male-female ratio of 3:1, and often occurs between 20 to 40 years of age. And the hip involvement is about 30 to 50%, and the bilateral affection is about 90%. So what is the aim we are looking for doing the THA in AS patients? To give a pain relief and the eradication of flexion contracture, because most of them are having a lot of flexion contractures, and the increased range of motion of the hip joint and improved mobility, and of course for the correction of posture. So preoperative conditions, always anticipate difficult anesthesia, because spinal is also always difficult giving in that patients. Intubation, sometimes nasal intubation is required or endoscopic intubation is required, and blood should be very much reserved for those patients because it bleeds a lot. So whole spine should be examined, especially the pelvic obliquity and the lip length discrepancy, and especially the status of the contralateral hip, bilateral knees, and integrity of the sciatic nerve. And about the expectations from the surgery, what the patient expects, that is also a very important consideration. The whole spine and pelvis should be radiologically seen, and in case of pseudoarthritis or very much intense spinal involvement, a spinal consultation should be obtained. So about the CT scan, it gives you a good idea about the pelvic obliquity and the bone stalk and the medial wall. Medial wall is almost always deficient in these cases, so that could be assessed by the CT scan and of course the femoral canal diameter. If the patient is on methotrexate, he can continue, but if he is on biologics or TNF alpha, then it should be withdrawn 4 to 6 weeks prior. Templating definitely gives a femoral size and about the cup placement, but the rotation and obliquity is very difficult to assess, or difficult to and may not be accurate. So modular implant can be used depending on the proximal morphology. Coming to the technical consideration, it is very technically demanding, especially the patient is having ankylosed hip. We look for the positioning of the patient, femoral neck cut, which is very important because the space is very less. Original joint line identification I will come on, and acetabular component positioning and adequate soft tissue release. So we, of course, we do the lateral debicutus with the sacral and pubic support. External rotation deformity, I'll just give a stress on that if you are having external rotational deformity, then posterior approach should not be done, because assessing the neck and approaching the neck is very difficult through the posterior approach. Tissue release is very, very important, which if the adductor is tight, you have to do adductor tenotomy. Iliopsoas muscle release has to be done in each and every case in an enclosed hip, of course. And the gluteus maximum release and anterior capsulotomy is being done for those cases. And there is a caution that forcible correction of the flexion contracture, if you are doing it without any soft tissue release, there is a chances of fracture of spine with a very bad neurological consequences that you should be very careful about that. And the flexural deformity, always sciatic nerve is at risk, so we have to take care of that. So femoral neck cut, definitely we do a V-cut osteotomy to increase the space between the cut portion, and then we can approach the acetabular. So sometimes it is required. And acetabular preparation, whenever it is required, never hesitate to take help of image intensifier, and direction of the reaming can be assessed with the help of image. And joint line identification, of course, image gives you a good idea about that the joint line has come, or the flakes of the articular cartilage of the head. That gives you a rough idea that the joint line, you are approaching the joint line. But of course, so many times you cannot get the whole flake of the articular cartilage of the head. So if you are getting a piece of that also, that gives you a rough idea about that. In the presence of pelvic obliquity, accurate positioning of the vestibular component is technically very difficult. In a flexion deformity, anterior tilting of the pelvis is there, and the malposition of vestibular component often results in anterior dislocation. To avoid those, we can decrease the anteversion, which reduces the chances of anterior dislocation. So there is a fixed pelvic obliquity. Where there is a contralateral hip is an abduction position, or is fixed in abduction, so that goes, the diseased hip goes in the cephalad way. So you have to incline your reamer in such a fashion to reach the scapula. That you have to take care of. So if the contralateral hip is fixed in abduction or adduction deformity, determining the true inclination of the vestibular cup is very difficult. So the pelvis is tilted cephalad if the contralateral limb is fixed in abduction deformity. So these are few cases. It's a 27-year-old male, ankylosed hip. So PHR has been done. Another case that was a very difficult case, I think I have done one of the most difficult cases. So right hip is okay placed, but the left hip is completely enclosed in completely in external rotation. So see the lateral view. So PHR has been done, and bilateral is done, and at least he was completely bedridden, and at least he can walk independently. It's a young boy. This was the case in which this was done by me 18 years back. Cemented bilateral PHR, and aseptic loosening was there, and so these cases needs a revision now. So coming to the complication, there's an anterior dislocation of hip can occur, and there is susceptibility to spinal fractures. I will take one minute. And there can be a sciatic nerve palsy or intraoperative fracture at the level of the calcar femoral, and these fractures have been managed successfully with the circumferential wiring. Aseptic loosening, definitely the main reason for revision surgery, and heterotrophic ossification. This I wanted to show, that is the AS case. This is a lateral view, and while doing the THR, you can see there is a fracture at the medial wall. So while doing it, I assessed it. So I put a bone graft and then did my job. So my take-home message is proper assessment is of utmost importance for THA in ankylosing spondylitis. Adequate exposure and release is very important, especially to release the flexor contractions. Restoring biomechanics of the hip, identifying true acetabulum, and never hesitate to take help of image intensifier. Inclination and anteversion should be taken care of to minimize chances of anterior dislocation. Cemented versus uncemented is the surgeon's choice, but good long-term survivorship has been reported with cemented DHA. Thank you very much.
Now I would like to call upon Dr. Ramakan to talk about long cylindrical stems in DHA.
Good afternoon, everyone. So I'm going to talk about long cylindrical stem in PHI and what is the current scenario. So as we all know that number of PHR cases are increasing, and so is the number of revision PHR cases. But the biggest challenges in revision cases are vestibular and femoral bone stock deficiency and achieving initial stable and long-term fixation. So before going further, just have a look at the velocity classification we are all aware of. So there are multiple options to bypass the femoral defect. The options are long cemented stems, proximal coated stems, and long distal fitting uncemented stems. As we all know that long cemented stems and proximal coated stems, they turn out to be a very poor medium-term and long-term results in division scenario. So the option remains with us is long distal fitting uncemented stems. So basically there are two types, non-modular and modular. Non-modular, they are usually fluted or tapered or fully coated. While the modular stems are usually fluted and tapered. So the first stem was introduced in 1980. That was fully porous coated stem, and it was fully coated, cylindrical, made of covert chrome, which is a very stiff material. It achieves initial fixation by distal fitting and long-term by biological include. So the disadvantage here is difficulty in removal, proximal stress shielding, high pain, and questionable performance in type 3B and type 4 petrosity favorable defects. And also because of its stiffness, it's made of covert chrome, so it's very stiff. You have to be very careful while inserting it. There are high rates of intraoperative fractures during insertion of fully porous coated stems. And certainly, it has shown a very good long-term survival signal and very good term result on long-term basis. Another stem is fluted stems. They are made of titanium alloy. Titanium is less stiff in plant. The design is usually fluted and tapered. It has got longitudinal ribs, which provides rotational stability, and tapered geometry offers axial stability. Less stiff as compared to fully coated, so less stress shielding. There has been a report of bone reconstitution after reconstruction of coated stems. Indications better coated in type 3B than fully coated. Excellent plant of choice in pain, prosthetic fractures, and especially favored in situations of complete loss of proximal bones like tooth prosthesis. Good results, long-term results have been published in different series. Modular stems, you can, there are two components, proximal and distal. You have to, prepare both separately. They have an advantage of adjusting leg length, offset, anti-version, and soft tissue tensions. But modularity comes with a concern. There are concerns of early junctional failure, possible increase in subsidence, wear debris from modular junctions, and the cost of implants. So there are studies which say that this implant remains a reliable and safe option for complex femoral repair operations. This is the comparison chart. There are multiple complications that we listed like subsidence, intraoperative fractures, thigh pain, proximal stress shielding. So subsidence has been seen highest in the fully porous coated stems. Intraoperative fractures highest in fully porous coated stems. Thigh pain highest in fully porous. Proximal stress shielding highest in fully porous coated. And the most favored stem in type 3B and 4 is usually modular or non-modular. So there are two scenarios in which we have revised femoral aspect, revision THR, and sometimes it's primarily indicated in IT fractures. So this is a case of 30-year-old lady with a fracture of the stem. This was revised using long Wagner stem and dual mobility curve for the sternal side. This is 3-month post-op X-ray. This is 6-month post-op X-ray. She's doing well. Average interval 86, 37-year-old male, morbidly obese, non-immunopathy fracture on the left side. So again, I did an implant removal and put a dual mobility cup on the sternal side and long lateral stem on the femoral side. This is the immediate post-op X-ray. This is 4-month post-op X-ray. This is 8-month post-op X-ray. This is video you sent me yesterday. It's walking comfortably without any pain. Another scenario, 75-year-old male, stem neck fracture, 1.5-year-old and cemented bipolar. This was again revised. Implant removal was done. I did an ETO, removed the implant, put a granular stem on the femoral side, dual mobility curve on the sternal side, and ECM is doing great. Another patient, 77-year-old lady with failed PFN. Again, implant was removed. On the sternal side, I had to do some bone grafting, and on the femoral side, I used the Wagner stem, rotator stem to one inspection. This is the lateral view of the same patient. Another case, 74-year-old male with failed THR, both the sternal and the femoral side, cemented THR. Again, it was revised. This is the intraop images. I did an ETO to remove the femoral implant. Here are the intra-op images. And this is the immediate post-op picture. Play it again. So this is the immediate post-op photographs. ETO locked diagnostic on the femoral side and normal isolated curve on the stabler side. Another 6-year-old male with filled bipolar. The implant was loose, so revised it with the help of DHR, long stem on the femoral side and normal insulated cup on the stabler side. Another patient, 78-year-old lady with a periprostatic fracture. So there will be a lateral view, again revised with a THR, unsegmented cup on the stabler side, and it has solution stem on the femoral side. So the conclusion is the ideal stem in revision THR remains undetermined. Fluted stems are widely used in all revision scenarios with favorable results. Modular fluted stems, they are not proven superior to non-modular. Fully porous stems showing a declining trend in view of high incidence of proximal stress reading and thigh pain. Thank you.
Thank you, Dr. Anuj. At the end of this session, I would like to invite Dr. Ashish. He is going to speak on the THR in acute acetabular fracture.
Chairman, I request Dr. Dr. R. not in the hall. Dr. Usmani, please come on the dais. First speaker is Dr. Sujit Kumar, PIP joint restoration post-trauma.
Can I go ahead, sir? Yes. Good evening to everybody. Hand is a probably a straight line topic. Definitely a straight line top. So, more the specialization, lesser is the involvement either in terms of the job done or in terms of the delegates. We can take some of the example. The fracture of the toxin phalanx extending up to the joint is not as per se PIP joint, but having an involvement of the joint too, with a rotational deformity. One can treat it very well by putting a multiple screw in the plane of the fracture. So one can go for a open reduction, internal fixation to prevent the rotational deformity across the fracture site. As we go with the case number 2, pathological fracture of the middle phalanx with the intra-articular involvement with the displacement of the PIP joint. So what we have done? We have done the open reduction, curettage of the lesion, bone grafting and the fixation by using a mini plate. So once you are going to restore the anatomy, early mobility and the good rehabilitation is possible after the restoration of the anatomy. PIP joint fracture dislocation results in the unstable dorsal displacement of the middle phalanx due to disruption of the attachment of the volar fibrocartilaginous plate. So one has to be very careful how you are going to repair the volar plate. That is one of the important factors. Same time, you must be able to isolate the collateral ligament, do the possible lengthening of the collateral ligament. So you are going to visualize the joint directly in end-to-end position. Dislocation of the PIP joint. First, it's easy to relocate it by traction, by manipulation. But when the patient is coming late with the presentation, the relocation simply by distraction or by manipulation may not be possible. They will require open reduction, either one can go through the dorsolateral or more comfortable to go through the volar approach in my hand. So once you are going to do the open reduction, same time the collateral learning is possible. So as you are going to do the hyper dorsiflexion at the PIP joint, you can remove the fibrous tissue from the dorsal part of the finger with the collateral learning. The reduction is possible. As you are going to reduce it on the volar side, one can put a block on the dorsal side, so early mobility in terms of the flexor is also possible. So this is another example. Now take an example, a patient who is coming with a late presentation of the PIP joint fracture dislocation. Usually the distal fragment goes on the dorsal side. In a fresh fracture, it's possible to put the dorsal block wire. If the fracture is small in size, either, or one can put a Suzuki frame in such cases. Patients who are coming late with such presentation, the close reduction maneuvering may not be possible. So one can go for a shotgun approach by putting incision on the volar side. Although this is not exactly the same picture what we had seen in the previous X-ray, but this is the way how you are going to approach from the volar side. Identify the pulley, open the fracture site, hyper dorsiflex the PIP joint. So you are going to choose the end on position of the fracture site. Reduce it anatomically if possible. If not possible, one can replace it by another technique. The small fragment can be replaced by the hemi-lunate. One can go for a hemi-lunate arthroplasty. In this patient, we have done the open reduction, fixation by using the mini screw, the titanium screw, repair of the volar plate, and the screw size was 1.8 mm in diameter. After this, one can do a reduction following the collateral lengthening, and early mobility is possible. As you are going to mobilize it, even after the 15 days after the mobility, one can achieve a good functional outcome in terms of the extension and flexion at the PIP joint. The success lies in the early mobility without pushing the joint in the hyperdorsiflexion. So this is one of the examples. In cases of patients where the reconstruction of the volar part of the joint is not possible, one can think for a hemi-lunate arthroplasty. Do the excision of the small segment of the lunate can be removed, can be transferred over the distal part of the proximal part of the middle phalanx, and this can be replaced by putting a smaller piece of the lunate. Fixation again by using either 2 or 3 multiple screws, which is possible. One can reduce it anatomically at this particular time by visualization of the end-to-end position. So early mobility is possible with a possible hope of getting good functional outcome of the patient. In such hopeless patients, where the patient mobility is very much limited, the reconstructive surgery is going to create a lot of hope for such patients. So this is the surgical outcome after the hemi-hamate arthroplasty. Every time, this is not necessary to think in terms of the surgical intervention. A patient by chance came to me for some other condition. He was having a good mobility with such kind of bad radiological appearance. He was having a good flexion at the PIP joint and at the same time having an excellent extension at the PIP joint. So do we really require to intervene when the patient is coming with a difficult situation, like thinking in terms of the arthroplasty may not be a very good option in such condition. Even doing arthrodesis may be a very good option in a difficult situation where patient is having a painless, where painful and compromised PIP joint function. So functional arthrodesis is equally a going to give you a good outcome at the end of the day. So every time, whenever you are going to see the problem in terms of the fracture or dislocation or patients who are coming late with such kind of presentation, it depends what kind of functional outcome you are going to give to the patient and what is the expectation of the patient. So these are the points has to be taken care at the time of the surgical intervention of the PIP joint. PIP joint injuries are complex and needs early surgical intervention, good functional outcome. Residual functional compromise may be devastating in active and demanding patients. Thank you very much.
Thank you, Dr. Sudhir. You have finished within the time of such a complex fracture, which definitely requires a lot of discussion. Thank you.
The next speaker is Dr. Saurabh Chaudhary, and he will be talking about carpal tunnel release and nuances.
Good afternoon, everybody. I'll be talking on the technical nuances in open carpal tunnel release. Now, what a carpal tunnel syndrome is known to everybody. It's a bread and butter surgery for all hand surgeons, and most of us operating surgeons are also doing it. So, it has been described as deceptively simple surgery, and I would say it is simply deceptive in certain cases. The tricks that I will be sharing are mainly to how to avoid the pitfalls. Now, in up to 25% of the cases, there are various complications which may lead to a dissatisfied patient. There may be a scar tenderness or hypersensitivity, there may be build-up pain, there may be recurrence of symptoms or recurrence of stenosis, injury to certain vital structures. So, mainly I will be discussing on how to expose the ulnar nerve and release it in a safe way, preserving all these important surgical structures. Failure can be categorized in 4 different categories. A case where the diagnosis made was wrong, maybe cervical radiculopathy. A case where the nerve was badly compressed for a very long duration and it has very poor potential of recovery. Poor surgery, and that is what we'll be talking about, and sometimes just poor. So I'm not talking about the diagnosis part. How to avoid a poor surgery. So there are certain vital structures which are lying in very close vicinity to the incision that we put for carpal tunnel. And we need to be aware of each of these structures, where do they lie, so that we can safely avoid them. So there is a superficial palmar arch, there is a thinner branch of median nerve, pterygium branch, palmar branch of median nerve, and ulnar nerve, ulnar artery and nerve, the main trunks, and the main trunk of median nerve itself. So we need to revise a bit of anatomy, and we all are very fond of studying anatomy right from our previous days. So I'll just share a few slides which will highlight the important anatomical things which will be very useful. So you can just pay attention for next 4 slides. The first slide is that showing the ulnar artery and ulnar nerve. Their location is slightly superficial to the transverse carpal ligament. They lie almost along the ulnar border of the ring finger. So if the incision happens to transgress more towards the ulnar side, these structures are likely to get injured. They lie superficially, so the best way to avoid them is to make our incision slightly laterally and at the same time go for a blunt dissection. As we dissect deeper, we see the superficial palmar arch, which is a continuation of the ulnar artery. Now, as you can see in this slide, it is very close to the distal extent of the transverse carpal ligament, and the nerve which is crossing in that area is the cutaneous branch of the third interdigital space, which is a branch of the median nerve. These 2 vital structures are limiting our surgical dissection distally, and we need to be aware of these to safely avoid them. Superficially, we have a palmar cutaneous branch of the median nerve as well as the ulnar nerve. So, if you see this slide carefully, there is a internervous plane in between these 2, and that is the plane that we will be targeting. And this plane, if you can see in this slide, it is lying more towards the ulnar border of the palmaris longus. So the cutaneous branch of the median nerve passes over or lateral to the palmaris longus, and as long as you stay medial to that, you are very less likely that you will injure that particular nerve. And this is the commonest nerve which gets damaged and which leads to a dissatisfied patient. Now we have learned how the important anatomical structures are lying, but sometimes what happens is the release is insufficient. So the transverse carpal ligament with the bony attachments is just the second zone of this shown in this diagram. Proximally as well as distally, there is a condensation of fibers of the flexor retinaculum, and which may still persist as a constricting band, and which needs to be thoroughly released for a good release. So in this diagram, as you can see, the median nerve is lying lateral to the palmaris longus tendon, and as long as our exposure is towards the ulnar side, we are safely in an internervous plane as well as safely away from the cutaneous branch. So marking the tendon, incision has been described along the Kaplan's line. The distal extent is along the Kaplan's line, where the line meets the radial border of the ring finger. Sometimes we tend to deliberately go a bit more ulnar so that we stay further away from the median nerve, so that when the healing is happening, the scarring is there, that does not encase the median nerve. So we are transgressing more towards the ulnar side. We are probably coming closer to the ulnar artery and the nerve, so we just have to be careful towards the ulnar side. We are safely away from the palmar-cutaneous branch of the median nerve. So this is how I usually do this marking. I just pull up the thinner and hypothinner muscle bulks, and there is a V there. I mark that, and proximally we extend it, and if at all needed, we can extend along transversely along the palmar crease, and then go longitudinally if required. The initial incision is just put up to the subcutaneous plane, and then we go for a blunt dissection. We separate the fat, and we usually see fan-shaped thin fibrous tissue, which is the palmar aponeurosis. Sometimes we may have some muscle fibers in that. Deeper to that, you see transversely running thicker fibers, that is a proper transverse carpal ligament. We make a small dent entry in that carefully and pass a blunt instrument, carefully dissecting the undersurface just to be sure that there are no adhesions on the undersurface. And you cut along the madronals over the median nerve and other contacts. And periodically you remove that and keep checking whether any adhesions are there and whether any other structures are close by in the incision field. Distally, as you go on, you see some healthy fat coming up as the constriction band is completely released. That is a signal that there is no further constriction, and that is also a signal that the superficial palmar arch should be very close by. So you need to be careful, and you may not need to extend any further if the pressure is all released. Proximally, again you have to check and you have to see how tight the retinaculum is. Proximally, if tight, you have to release it. And this is probably the full extent of the release. You can mobilize the nerve in the carpal tunnel and see whether any adhesions are there. If at all any synovial hypertrophy is there, don't forget to take a biopsy. And this will also show the various branches of major branches of the nerve coming out, and that is a signal that probably your entire extent of the nerve has been carefully decompressed. And this is how we check. We pass a blunt instrument underneath. We see that there is no compression over that. Now can be freely mobilized over the other contents. And distally again. And this is how we close it, subcuticular. I usually put a POP for 2 days, and right away I need to do it under local anesthesia. I ensure that the patient does full range of movement the same day. And this is at suture movement day 10. And I actively encourage the patient to use her hand as much as she can. So take home is safe surgery and complete release. For that we need to have knowledge of the relevant anatomy so that we protect the important structures in this area and do not leave any dissection. Thank you.
Our next speaker is Dr. Pawan Kumar, and he will be talking about phalangeal fracture.
बता दीजिए प्रोग्राम का में बताइए 1 मिनट बताइए परमिशन ले लीजिए पहले
with due permission from the chairperson I am happy to announce that we are having midterm symposium of central zone of IOA. We all know what central zone consists of. This is being held on 16th of April next month in BNR Chanakya in Ranchi. Dr. Sanjeev Gowar sir is the president, I am the vice president, and our organizing secretary is Dr. Rohit Lal, and Dr. Pradeep Chaudhary is the secretary of Central Zone. So I do invite everybody to do come over to Ranchi. It's my warm hospitality from my side. Again, I do invite. Thank you.
Our next speaker is Dr. Pankaj Jindal. He is very famous hand of microsurgeon. He is one of our friends. And he is from Pune. He is doing a lot of things, and he is really student of Professor and he is doing a lot of work in the hands of the microsurgery and general orthopedics. Okay, please.
Thank you, sir. From chairpersons and delegates in the auditorium and before the auditorium, we'll talk about few tips and tricks in fracture of the hand. Clinical assessment is more important than any investigation. If you don't make a diagnosis, don't jump to an MRI. Clinical assessment is going to give you practically all the information that is required.
This is for 25 minutes. You have shown.
Thank you. Probably there are 3 or operations, Dr. Titi Tanna, one from GSK, probably this is the third one here. So if you have a young child, 6 years old, howling after a sharp injury, she's not going to tell you anything here, and you have to suspect. A suspicion after a sharp injury, probably patient has a nerve injury here. And sure enough, under anesthesia we explored, and she has a nerve injury here. A complete examination of hand will include, first and foremost thing is whether there is a good vascularity of the tip here, followed by how the skin condition is, whether the skin is lost, because you have to make provision for appropriate skin cover, whether that is skin grafting or a flap, followed by assessment of tendons, nerves, bones, ligament. If it's a road accident, assess the brachial plexus, because this is the one which may not show up anything. After a few months only patient says, hey, I cannot lift up my shoulder. So first thing, circulation. Assess the blanching of the tip, the turgor on the tip. If the turgor and blanching are there, that means the circulation is good. In spite of a grotesque looking injury here, just stabilize with the K-wire and the part is going to go on to good healing, provided the tendons and nerves are intact here. A small injury is the one which are often going to miss a lot of things which are underlying here. A sharp injury should raise a suspicion of a nerve injury, and therefore always check the examination of the sensation distally here. If the distal sensation is absent, explore and sure enough you will see a digital nerve which is cut here. A major injury, an industrial injury, doesn't mean you need to go on to an amputation. See, the small finger is intact. Major part of the ring finger is intact. Major length of the proximal part of the thumb is intact. Probably the problem is in the other two fingers here. And therefore, if you can restore somehow the thumb, restore the first leg space here, I'm sure the patient will have a good functioning hand here. Coming to the X-ray, two views which are just neither PA nor lateral is no good. You have to have a 2 PA and a 2 lateral, and that 2 magnified view to make some firm diagnosis like this here. If you are assessing a finger, getting a lateral of the finger is absolutely essential, rather lateral of the hand. With the finger superimposed, you will make out nothing here. And therefore always insist for a lateral, a 2 lateral of the finger. A fan out view is again no good, especially if you are seeing a fracture dislocation. And how to suspect a fracture dislocation? To suspect fracture dislocation, it's usually a cricket ball injury in our country with a restriction of PIP joint injury. And again, get a huge magnified view of the affected part which is tender, and that is going to be a clue to the diagnosis here. If you don't see anything but the history show of a fallen outstretched hand, especially the tenderness on the ulnar side here, suspect a collateral ligament injury. And if you do a stress X-ray, you will see a wide opening on the ulnar side here, and this is a gamekeeper's thumb here, which can be fixed with some kind of a screw here. The next thing in the hand is no wound is superficial unless opened, explored. No wound is superficial like this boy with a glass injury here. A small entry wound, and we explored it and see so many glass pieces were extracted out of this tiny looking wound here. Therefore, always explore the wounds here. A tiny looking wound here, but see, this is drooping. This is an extensor tendon injury, following a monkey bite here. You need a magnification. If you don't use a magnification, it's a one-time investment, it may cost a lakh, but upgrade your car a few months later, but buy a magnification. You will enjoy surgery of the hand, you will enjoy surgery of the spine as well here. A tourniquet is an absolute must. Get a good quality tourniquet, a pneumatic tourniquet. Ash mark is the commonest cause of a wrist drop here. You can raise it to 100 over systolic. Use the widest possible cuff on the forearm here or the arm here. Use a generous amount of cotton padding here, and 1 to 1.5 hours is a safe tourniquet time in majority of situations here. For hand surgery, you cannot replace the instrument used for femur and forearm with a finer instrument. Use the finer instruments, and again, it's a one-time investment, and you'll enjoy surgery of the hand here. Do not repeatedly open the wounds in the ward, because that's the best way to introduce a lot of contamination and infection in the hands here. One time opening, take a photograph and share with your seniors here, but do not open it again and again here. Do the surgery in the main operation theatre, not in the septic theatre here, because walk-in theatre is another cause of contamination and infections here. Coming to the suturing, do not use deep bites. Use very superficial dermal sutures, no strangulating sutures. If you are in doubt, leave it open. Use thinner sutures like 40, 50, 60 and keep long here, and do not go on to 20 or 10 if you are not able to close the wound. If you try to close it with a thicker suture, you are heading for trouble here. If in doubt, leave it open, or use a graft or use a flap here. Like this case here. This very likely would have gone to good healing if these ropes were not used. These are literally ropes here. Do not use this triangulating sutures here. What we are seeing here is a venous engorgement. The only thing I did was remove the sutures and went on to good healing, which was an imminent discoloration of the fingers here. Wound management, the most important thing in an acute situation, the patient's wound is contaminated. It is not infected. And the aim is to convert this contaminated wound to a surgically clean wound. Aim for zero infection. And the best thing is wash it thoroughly with generous amount of saline, just not a syringe full of saline. Use a generous amount of saline and clean it as well as possible. Copious amount of normal saline is more useful than tons of antibiotics here. Wash every nook and corner of the wound thoroughly here. Sometimes it may take 2 hours, 3 hours or 5 hours, but clean it thoroughly to convert a contaminated wound to a surgically clean wound. The best antibiotic that I use is the first generation cephalosporins or ampicloxacillin. Rarely would go to ampicillin if the patient is on a farming injury. Probably I have not used metronidazole for a long time here. But if in doubt, take the help of infection control specialist here. And this would be the base slide I would say for management of the open injuries here. Debridement followed by skeletal stabilization followed by repair of tendons now the vessels are required. Non-constricting skin cover and followed by dynamic sprinting here. Take this example of open fracture of the radius ulna. Thorough debridement is extremely important. Putting a bottle of hydrogen peroxide is no good. Hydrogen peroxide is only a surface phenomenon of frothing here. Debride, debride. It may take several hours. And this is followed by skeletal stabilizer, which consists of KY as external fixator. And once this wound is open, stabilized, covered it primarily with a groin flap or whatever flap here. And this goes on is followed by rehabilitation for a zero infection here. Coming to the K-wires, use sharp K-wires. Do not reuse K-wires here. It's only 12 rupees. But loose wiring is only happening if you are reusing not so sharp K-wire here. Use short bevel, I'll talk about it. Use diamond point, I'll talk about it. I'll talk about the long bevel. And what that means is, do not use blunt K-wire. This is not going to give you a purchase. Use one with a short bevel. If you are using a long bevel or a longish bevel, it's not good hold. So use a short bevel here, but do not use a blunt K-wire here. A very important slide here, if the K-wire is going right through the center, it is going to pit the extensor tendon, and this will prevent the gliding of the extensor tendon and prevent PIP joint flexion. So loss is to the extent of 34 degrees. 34 degrees of PIP is restricted. But if you just move a millimeter laterally, the loss is 17 degrees. But if you take this K-wire further laterally, the restriction is 12 degrees only. Therefore, keep your wires not in the center, but go away from the center so that it does not restrict your PIP joint flexion here. And as Dr. Pawan Kumar was saying, elevation of the heart level is very important. It increases, enhances the venous drainage, and sling is absolutely useless. It only promotes Jindal Institute of Hand Surgery. It's only for my promotion, but it's bad for the patient here. Non-functional position is another cause of severe pain, and giving rise to a stiff hand, and therefore keep the wrist extended and MP joints flexed here. Again, extending the plaster up to the PIP joint with the MP joint extended, another cause of major stiffness here, which some may call it a CRPS. This is not CRPS, this is stiff hand. The stiffness caused by a poor plastering here. Let's take a clinical, this is a common scenario, and the commonest scenario is a fingertip injury here. A common fingertip injury is following a finger getting caught into a door, following a heavy wind. This is usually a dorsal injury, the nail is reversed, but the skin is intact on the volar aspect. The skin is intact on the volar aspect. Just what you require is anesthesia. Local anesthesia, howling child, this whole thing is going to get yanked out, and the part is going to get amputated here. And therefore, general anesthesia, gentle handling, no tight suturing, and you are done. Repair it with the nail bed with 60 chromic catgut. If you have it, very good. But stabilize with a hypodermic needle number 26 gauge needle or a K-wire, a very thin K-wire, and you will do justice to this thing. There are other situations where amputations can occur, a molar applic amputation which can be covered with a cross finger flap or a V-plasty or a thinner flap. And all these flaps are possible depending on the direction of the injury, but do not put strangulating sutures and try to shorten the finger and close the finger and give rise to a job loss to these patients here. You can save this patient by using appropriate flaps as I have just mentioned here. Coming to an amputation of the thumb, do not aim for coverage of the wound. What is important here is a functional restoration. And how do we restore the thumb? The aim should be primarily decided, and the aim is getting the thumb here. And how do you get the thumb? It is, of course, you can see the malrotation of the finger here. So of course there are fractures of the metacarpals and phalanges here. First thing we did was a groin flap here, because we are planning to get the thumb back on this patient. And now he has 4 fingers and no thumb. And what we did, once the wound had been healed, we transferred the index finger and did polycization here to restore the hand function here. Again, don't jump to an amputation. This patient was airlifted to our city here, and just see, because this finger is amputated, it's dying, just think of amputation is no good, because there are no known vessels available molar aspect here. We debrided it, prevented an amputation of this thing temporarily to start with here, and covered with the groin flap. We got some groin granulation tissue here, and then advanced this flap on the flap here, and then polycized this stump of the index finger. We had a lot of tendons available for occurrence plastic, and sure enough, we had a reasonable function. The patient's amputation was avoided. There are third situations where the parts are just punched out here. Again, you cannot close this wound because there is hardly any skin available. These parts were brought with the patient in the glove he was wearing, and these parts were grafted in the middle of the night with the metacarpals, metacarpophalangeal joint, flexor tendons, digital nerve. Digital nerves also there, and these were also grafted primarily. On the molar aspect, we put a flap there. This is based on one of the branches of the ulnar artery, and these were fixed here. On the dorsal aspect, we did a primary posterior interosseous artery flap. So 2 flaps. This was sandwiched, and both anterior posterior we had flap, and we could save this hand from imminent job loss here. Think of a nerve every time you see a painful condition. This is no good. Patient has pain in the abdomen, you put this hot rod in the abdomen. No, this is not the way. We have to identify the cause of the pain rather than doing this kind of treatment here. Like this patient, he was being treated by a dermatologist for this injury, but what was the sensation? He had loss of sensation in 3.5 fingers. Probably it was no attention was paid to the laceration he had on the wrist. He had a median nerve injury leading to insensate median nerve distribution here. The next situation is here. Side-to-side nerve repair. This is historical. This is no good. It's not going to restore any kind of function here. Nor this situation where nerve is repaired to the tendon. Nerve is lying here. A good magnification will give you all the details, and you can do justice to this surgery. Coming to the next part of hand surgery is the delayed or neglected presentation. A patient with a fracture of the radius and ulna, not admitted after close reduction. For 3 days the patient was shouting. First time the patient says he has pain, we should identify the cause of the pain. Is it compartment syndrome? There is been stretch pain there, or plaster is tight, or the patient's hand is in non-functional position here. An external fixator was put in 3 days after the plaster was removed, and the patient has already started to lose a sequestrum of the radius. Ulna was projecting out, and then attempt was made to make a single forearm, and that went on to non-union. And then skin grafting, the median nerve was lost, the flexor tendons lost, and the patient had already undergone 14 operations here, and that was the schematic of the presentation of the patient here. So first thing, we used dynamic splints to mobilize the MP and the PIP joint here. Then a compression device was made to compress the non-union into a union here, and thus a union and stable wrist was achieved here. And this was followed by a groin flap to replace the skin grafted forearm here. And then only 2 problems were remaining, the median nerve loss and the tendon loss. We harvested sural nerve from the leg to restore the integrity of the median nerve, and ACR tendon was mobilized from the dorsum and brought into the front, and FTP was reconstructed. Did it work? Sure it does. This was the kind of flexion extension we got to this patient here. Similarly, this girl was burnt at the age of 3 years here, and the thumb was glued to the palm here. And we mobilized with a flap from the dorsum of the index finger, and the first web space was opened. And then this was followed by dynamic splinting to keep the thumb mobile here.
And a girl who had never written in her hand at 1 month was able to write beautifully and use the hand for eating as well here. Coming to the pain, pain is not muscle pain, muscular pain or myofascial pain. We should identify the reason of this pain. We just heard about a beautiful lecture on carpal tunnel syndrome, but there can be more proximal problems as well here. Like this, every time she flexed, he had pain in the upper part of the forearm here. And this was pronator teres syndrome here. And the pronator teres syndrome is the medial nerve compressed under the arch of the flexor digitorum superficialis. The moment we cut this arch, the pain was gone here. All nerves are prone for getting compression. Like I said about the medial nerve proximally, the ulnar nerve can be compressed on the medial aspect as well. Look at the patient. The patient is telling you the surface anatomy of the nerve. If the patient says I have pain on the small finger side, assess the ulnar nerve for sure. If the patient says pain on the radial side, assess the radial nerve for sure. If the patient said I have central pain, look at the median nerve. Like this lady had pain on the ulnar side, and sure enough, it was the ulnar nerve which was compressed. Like on the radial side, if the pain is on the lateral epicondyle, we are looking at, of course, the tennis elbow. But if the pain is more distal in the soft tissue, in the outcropping muscles, you are looking at the radial nerve compression. What is radial nerve compression? It is the motor branch of the radial nerve getting compressed in the two pulleys of the supinator here. Like this patient here. The motor nerve is going inside the supinator, and if you release this, the pain will be gone. Every time you see pain, identify the cause of the pain, and usually the structure which is underlying is the cause of the pain. Like this. This is the prominent first CMC joint of this lady here. Usually lady is in the middle age, and if you press this, if you attack the first metacarpal, this will precipitate the pain. And this is what is called as a basal joint arthritis, the first CMC joint arthritis. So what you need to do is, you see the arthritis here, you see the sclerosis of the trapezium proximal here with the articulation of the scaphoid. That means the patient has arthritis of the trapezium. If you excise this trapezium here, the patient's pain will be gone here. Excise this trapezium, put the patient to a cast for about 4 to 5 weeks, and let this get stable here up. It will not telescope, it will not shorten. The patient will have an excellent function in a few weeks' time here. Like this patient, the length is maintained here, and the patient's first metacarpal is now articulating with a gap with the scaphoid here. Congenital anomaly is something very important to mention here. When we see the children, we say come when you are adult, and when they come as adult, they say why did you come when you are early? And therefore both the opportunities are not appropriate. The best time to do any correction of the congenital anomaly is the first or the second year of life. And congenital for like this patient, the best time to do operations on these hands is the first year of life. Why? Because the integration of the mobilized thumb is best when the child is not yet learned how to use the thumb here. And therefore make index finger into a thumb in the first year of life, polysize it so that the integration with the brain is fastest, and therefore offer surgery to these patients early on in life there. Therefore do this polycization first year of life. To achieve function, the most important thing you need is dynamic sprinting here. As Pawan was mentioning here, the most important thing is the biggest problem in hand surgery is getting a stiff hand. And the biggest stiffness that we see is the cluster with the MP joint extended. Keep the joint metacarpophalangeal joint flexed in the operating table itself. That night will be painful for the patient, the next morning will be painful. But now if you remove the cluster, the patient will have full function. But if you don't put the MP joint in flexion on the operating table, getting flexion is a nightmare for both the surgeon and the patient here. And therefore, MP joint flex is a very important thing for all patients, except probably some kind of extensor tendon. We will not go to the finer details here. All patients require sprinting. If there are no sprints, and that too dynamic sprints, you are in trouble. Like Professor Kanoja was mentioning, I worked with Dr. E.P. Joshi. The first day he said, you have to work in the workshop. And I worked in the workshop for a whole year, writing books and working for that person there, and learned the art of making all the dynamic sprinting here. And now, I have a 4-bedroom apartment, and 1 bedroom is taking sprints. Because you ask 100 rupees for this patient, he doesn't want to give. So I am willing to give these sprints free of charge to all the patients, because sprinting is going to give me the function. The best surgery may be done by today, tomorrow, or Pawan. But if sprinting is not there, I can guarantee it's going to be a stiff hand. And therefore sprinting is going to give me the function. A dynamic sprint to extend the PIP joint, a more difficult, high-profile aluminum splint with a turnbuckle splint with a butterfly screw to make the PIP joint extended. A loop here to flex the PIP joint. A first wave space splint to stretch out the first wave splint here. And this is the back room here. I make all the name the splint and I can make in the house within no time. It takes me a minute to make any dynamic splint not available anywhere in the world. And where do I add? Read. Keep reading. If you don't read, you are in trouble. Be analytical. Every time you listen to somebody, I don't agree with this person. Take a right. Buy journals and find the guru like I found. And whom did I find? I found everybody in this photograph here. I see Dr. B.B. Joshi at the far end, Harold Kleiner, with whom we worked for more than a year, and Sumo and Sai was another microsurgery at Kleiner. So I thank you very much. And he is another one, David Joang from Taiwan, spent on the 5 weeks. He enjoyed because I used to ask him so many silly questions. He said, I like people asking questions. I used to sit till 11 in the night explaining all the nuances of repair of the vehicle fixes. He said, when he was a student, he spent time with Narakas asking all these questions. Narakas was another big name from Switzerland, Lausanne here. So read, steal books from wherever, but you have to read all the books. I thank you once again for patient listening. Thank you.
Thank you, Dr. Jindal. You have elaborated the entire problems of the hand surgery in a very concise way and in a short manner. The best part, which I think, which is must for all the hand surgeons, is that in the last, which you mentioned about the split, because the movement is the main aim for any surgeon. Because unless you restore the function, your best surgery doesn't matter at all. Thank you again. Over to questions.
Thank you, Dr. Jindal. You have worked with Dr. B.B. Joshi. B.B. Joshi was also having one workshop with the patient for both the tricycle was running the workshop. And every day the same thing. He used to prepare the streams. I worked with B.B. Joshi in 1980. And Dr. B.B. Joshi with Ram Prabhu came here in Nalanda Medical College, and they stayed here for 7 days, and they demonstrated all types of hand injury here in Patna. They stayed for 7 days. This is the massive program they have given in Patna. I think no surgeon of his caliber can spend 7 days time in one state. Thank you very much for coming this place. Thank you.
Any questions from the audience? All the 4 speakers. No question. Thank you very much. We have to proceed to the hall A for the inaugural function. Thank you.